He means business, the business of academics, patient care, and research. Thank you, sir. We at SKIMS have lots of hopes from your leadership. I now invite Principal and Dean, Government Medical College, Srinagar, Dr. Ifat Hassan Shah. Please, ma'am, raise the stage with your presence. We have Dr. Ashutosh Gupta, who will be joining us online. I would now request Dr. Ruby Rishi, Principal, GMC Baramulla, to raise the stage with your presence. May I request Dr. Ruxana Najib to please take a chair on the stage. I now request Dr. Surinder Kayatri to please have a seat on the stage. Principal GMC Kochwa. May I please invite Dr. Amarjit Singh Bhatia, Principal GMC Rajouri, to please grace the stage with presence. I now request Dr. Rakesh Bahal, Principal GMC Doda, to please take a seat on the stage. We also have Dr. M. Gupta, who will be joining us online. May I please invite Dr. Khushi Devani, Principal GMC Handwara, to say. I would also request Dr. Ejaz Ahmed Shah, Principal and Dean, GDC Srinagar, to please bless the stage with his presence. And I would also request Dr. Parveen Elon, Principal Dean, IG GDC Jammu, to please bless the stage with his presence. May I now request Dr. Hilal to present a bouquet to Worthy Director from the Shogunai as a token of respect. Yeah. May I request Dr. Talha to present a bouquet of flowers to Dr. Ifat Hassan Shah, Principal, GMC Srinagar. I request Dr. Fahim to present a bouquet of flowers to Dr. Ruby Rishi. May I please request Dr. Fazil to present a bouquet of flowers to Dr. Ruxana Najib. May I please request Dr. Hilal to present a bouquet of flowers to Dr. Surinder Kayatri, Principal GMC Katua. I request Dr. Talha to present a bouquet of flowers to Dr. Amarjit Singh, Principal GMC Rajouri. Dr. Fahim may please bring a bouquet of flowers to Dr. Rakesh Bahal, Principal GMC Doda. Dr. Fazil may please present a bouquet of flowers to Dr. Khushi Devani, Principal GMC Handwara. Dr. Hilal may please come on stage to present a bouquet of flowers to Dr. Ejaz Ahmed Shah, Principal Dean GDC Srinagar. Dr. Talha may please present a bouquet of flowers as a token of respect to Dr. Parveen Elon, Principal Dean IGG DC Jammu. I would now request our worthy director, Professor Mohammad Ashraf Ganai, to moderate the much awaited session for discussions and deliberations. Sir, it's over to you.
Professor Shiv Kumar Serene, chief guest of this function, who is online, is director of Institute of Liver and Biliary Sciences, New Delhi. He is also president of our Society, National Academy of Medical Sciences. Welcome, sir. Our worthy principals of 12 medical colleges, dental colleges, and the Unani colleges across the UT of J&K and Ladakh. senior faculty members, scholars, scientists, ladies, gentlemen, boys and girls, good afternoon and welcome to this August function. At the outset, I express my gratitude to Professor Shiv Sarin for making it possible out of his busy schedule to be present there. As you know, on this day we tried to combine these two functions. One function is that we have made a network of all the medical colleges, dental colleges and Unani colleges across J&K for streamlining health system referral and also complementing, supplementing the deficiencies and the using strengths of various institutions across J&K for collaborative network. So we had a detailed brainstorming session in our boardroom, which was Administrative Secretary, Health and Medical Education also. So we had various discussions as per the mandate given to me as a chairman of the committee constituted by Government of J&K for streamlining various medical college in the UT of J&K Ladakh. However, it was my idea that we should also with this streamline the academics in these various colleges across J&K, UT and Ladakh and under the banner of National Academy of Medical Sciences. As you know, National Academy of Medical Sciences is a apex body which has been started at least some 60 years back, not by Pandit Jawaharlal Nehru, inaugurated it, and today this academy is overseeing and advising Government of India in various academic programs in medical and biomedical sciences. And we are fortunate to have a president, a very dynamic leader in the country for academics in medical sciences, Dr. Shiv Kumar Sarin. He doesn't need any introduction. All of you must have heard him. He is the man behind, he has started of his own the Institute of Liver and Biliary Sciences, New Delhi. And you must have seen many people go for liver transplant from here to that institution. And there is a very high-end state-of-art services in that science across at the global level. So, without wasting time, I would like to say, I request Dr. Sarin to tell us offer in J&K and Ladakh. Me, in the capacity of convener of this region, have already taken initiatives, and today we are inaugurating, and you are, sir, inaugurating this network of NAMs. Not only a cell we have created at SKIMS, not only in SKIMS, but a network across J&K Ladakh. All the principals, heads of institutions who are here are going to nominate a nodal person from their institution, and also they are going to create a cell in their respective institutions. We would like you to be physically here, sir, at some point of time in near future so that you visit and tell us how to go forward, because NAMS does not have much presence in this region. Over to Shiv Kumar Sarin, sir.
शुक्रिया जनाब गनी साहब और director SKIMS and all the learned principals, Dr. Gani Sahab and everyone. It's a distinct honor for the National Academy to be invited, and you have given a platform at SKIMS to the National Academy. It is your academy and it is your institution, the highest academy in the country. I want to compliment Dr. Gani for his perseverance, leadership. I have known him for a very long time, and I admire his perseverance, and his vision. Skims has always been a leader not only in Jammu and Kashmir but all over the country. Whenever we get residents from Skims, we know he has a very good internal medicine or general surgery. They are actually trained very, very well. So I compliment you. I also feel this is a unique day that you have collected all the principles of the region. What better way of communicating and learning? Nobody has done it. So, compliments to you, your team, and all the members who have joined. Very briefly about National Academy and two of its initiatives which you can start right away. The National Academy started on 5th of September with ICMR, a National Biostatistics Helpline. 5th September onwards, the National Academy is with ICMR available 5 days a week, maybe 6 days. Your students who need statistical help can just log on to either NAMS or ICMR Biostatistics Helpline, book their slots, get their questions, and work with the statistical best brains in the country from ICMR and about 20 fellows of the National Academy who are biostatisticians. So please use that. Please tell all your people you may have very good biostatistician, but some places you may not have them readily available. Second initiative, which started yesterday, and it is the triple II and NAMS. This is a AI and machine learning course which we started yesterday. We opened this maybe a week ago, and in 3 days, 215 young faculty members enrolled for this triple IIT and NAMS certified course on AI and machine learning. The new course will soon be launched, but you can certainly look at it. This course allows each one of us to learn on machine learning, and you all the students can do, and we are going to percolate it to every place. The NAMS has in last 2 years done few things which you may also take some benefit. One is a leads program, leaders in medicine. Maybe some people who are heads of departments or they are medical superintendents or principals. How do you take higher position and how do you become a leader? This the three leads program have been done. The fourth will be announced soon, so you can be part of it. I know SKIMS and the region has very good teachers. You can be a mentor. You can just say that I would like to mentor and send a mail, and NAMS will reciprocate. The next thing you can do, and I would request you to undertake, is the state level quiz. This is for undergraduates, graduates, maybe postdoctoral people, and you can have quizzes at your level and they will be certified. The winners can be included into the national merit list. We also request you to consider becoming an associate member. All those who pass MDMS with one single presentation at a national conference or one single publication or even a case report can become an associate member. DMMCH can become an associate fellow, which is a feather. Then people who have done 5 years as faculty or senior people can become members. And yes, you can also become fellows. Selection of fellows is very tough. Maybe out of several hundred applications, we were able to get the best 53 or 54 this year. The results were announced just 2 days ago. Then, if you have friends who are overseas and here they are very intelligent, very contributed to science, you can request them to apply for an international fellow of the National Academy. You may also like to say, we in this region want to have our problems to be sorted out and develop a task force. NAMS has done 29 task forces in last 2 years, but we may be lacking into what are the diseases, challenges which you face. One of them you are doing today is the stewardship in antimicrobial therapy. But ICMR already has several task force on that. You may think of something, maybe I'm not sure, some of the infections or some of the challenges that the region and your community people face. Certainly, you develop, propose a task force. Dr. Ghani Saab can guide, and a task force, you send a letter today, and we will respond today. There is no tomorrow. I would also like you to think about whether you would like to have some of your youngsters going into other institutions for training. We will support it. Also, the National Academy of Medical Sciences would love to have some of you join two programs. One is called Navigate CME, National Virtual Postgraduate Medical Education CME. This is done. Navigate CME. If you are a good teacher, join Navigate CME and teach. A whole lot of people in the country will listen. The second is AIMS and NAMS CME, which is done once a month. I think on the first Tuesday of every month, you and your students can join. Several of these initiatives I would like you to witness. The national conference and the convocation is in Jodhpur, AIMS Jodhpur, which is on 22nd to 24th November. I would like you, the principals, to probably send some students, they themselves, if they can come over, it will be a feather in our cap. Ghani Sahab and all others, I would like you to come. Why should you choose NEMS? Because it gets the best fellows. I may not be knowing who is the best, maybe in cardiothoracic surgery, but you have a fellow. Suppose you don't have a department and you want to start a new department, let's say neonatology or vascular disease or something. You have a fellow. The National Academy will support, send the emeritus or senior professor to your institute to start a new department. He can spend 7 days, he can help starting a new department. These are some of the initiatives of NAMS. I would like to say I would come over, but your inviting me is an honor to the National Academy, Ganisa. We are really privileged that you have invited the National Academy. You have set up a center there and you will set up a cell. Today we have 63 cells, NAM cells. Every medical college who can open a small space, provide some infrastructure, can be a NAM cell, and your region, you can be the state coordinator and run this place. The advantage of this is you get connected to maybe 3,000 members, 1,000 plus fellows, emeritus professors, international fellows, and maybe you yourself can contribute to enrich this academy. It is your academy, an umbrella academy, involves all branches, even engineering, even PhD students, all basic scientists are invited. With this, I would like to thank you to allow me to speak and compliment you, congratulate you, all of you who have joined today. A big round of applause to your group of people in Jammu and Kashmir. Thank you.
Thank you, Serin sir. Thank you very much. I know you how busy you are, but then you have enlightened us, and you have also told the audience that the NAMS initiatives. I actually we will be for next 20 minutes. We will be deliberating with the principals that how we go about creating these cells, how to fix nodal persons, and how to initiate these academic activities across J&K and Ladakh. So we'll be inshallah in future having CMEs, and also we will encourage many fellows and members to join, and we will also contribute as a resource persons for the Navigate CMEs, and also we have already put in students join the Navigate program also. Thank you very much, sir, for joining. And if you are not very busy, you can also listen to what we are saying. Otherwise, you could go ahead with your program.
Thank you. Thank you.
Your
Ganesh.
IT remains with us.
Yes.
Thank
Thank
you, sir.
you. Very best wishes. Have a great day and a great meeting to all of you. Thank you,
Thank you
sir.
very much.
Thank you.
So, as Professor Serin was saying, let me rephrase what are the initiatives of National Academy of Medical Sciences. These are this just to rephrase the same things. The first and most important is offering fellowship, offering membership, and associate fellowship. Our website, NAM's website, has all details there. And if anybody applies for a membership, who is a medico or a paramedico guy, and you have proper form to be applied, and you need two members to sign. And as a convener, I am to forward that form. And if you apply as a fellow is a little difficult. It has stringent criteria. It is very prestigious. I can tell you we have only 5 fellows in J&K. One is Dr. Nasib Singh Pakhania. I don't know, you must be knowing. He is very senior now. Dr. Madan from Jammu. Dr. Shakti Kumar Gupta, who is now Director AIMS Jammu. And from Kashmir, we have Dr. Kadri Saab, who has a lab. And then we have Dr. Muzaffar, who was Director General Health Services. And then I myself. So I have been the youngest fellow. That is why they gave me the chance of having this, being a convener. So being fellow is very prestigious. I request our senior professors and especially principals to put an application and put your research, put your initiative. I am sure that if I powered, they have put some sort of a bar for J&K and Ladakh lower for selecting fellowship. It takes some time for getting fellowship, but it is very easy to give it here. I think Dr. Pawan Malhotra's application I have forwarded. Next fellow, he may be elected. And for J&K, they may give some concession. So I request, first of all principals and senior professors here to apply for fellowship. Now, the other DM and MCH scholars and post-DM who are younger faculty can easily apply for associate fellowship. Then all other graduates, postgraduates can apply for membership. That is one. Second initiative is younger faculty can apply for small research grant up to 1 lakh rupees. Academy provides you research grant. The postgraduates can apply for their thesis work. 20,000 rupees can be given as a thesis grant. So that you can apply to our cell. I will forward those applications you will get. Somebody wants to conduct a CME program, for example, Dr. Mudassir Ejaz Saab is doing this today, antibiotic stewardship program. Similar one-day program you can apply and you will get 1 lakh or 1.25 lakh rupees as a grant. Then you can give me your application for being a resource faculty. Suppose if somebody is done as a faculty member, has done tremendous work in that, you think that you can be national level faculty. So you can present your data, you can give your research, and you can be a mentor for other people. There are these student and faculty exchange programs. You have international fellowships. Suppose you have to go for training to a foreign country, you apply, your program can be supported by NAMS. There are several other initiatives which, when you access the website, you will be supported. So I encourage all of you to visit the website. And we have actually started a cell at SKIMS. I think Ejaz Saab will inaugurate that today. All of principals we will visit that cell. We see where the cell is located, and from that cell we can have a network of cells across these medical colleges. So each principal can nominate one person who will be a nodal person, and you can dedicate one room and who can organize all these programs for your faculty students at local levels. So I congratulate Dr. Mudassar and Dr. Ejaz Saab for having this today's program. After we conclude, there will be a small interactive session. After this, the scientific program will start. So before scientific program, I can request maybe serially from some comments. You can come over and give comments about the NAMS. What do you feel about NAMS activity? How do you would like to go about this? Maybe if you can come on mic, or you can use the mic. Yeah. Dr. Bal.
Thank you, sir. Since we do not have any such cell in our institution also has no one. I'll first of all try to nominate, as you suggested, one senior faculty member and to start with the screener. And we will, I think, if you give us 1 or 2 months time, we'll have an established surface and we won't get dissatisfied.
Yes, thank you. Professor Ejaz Malik will share his email, his phone number, and you can select one nodal person. That nodal person can actually contact with him and he can guide him in various activities from time to time. And it will be very useful for teaching, training programs, setting standard of education, and also encouraging youngsters to the academics. This is a very powerful academy. And I do not know, because I was in AIMS as a faculty, that is how I entered into academy. And I don't know why there has not been much footprint of academy in Jammu and Kashmir and Ladakh. So they have put in Northeast also, there is little less footprints of academy. So they have put JK, Ladakh and Northeast on a special radar for increasing the footprints of academy.
Thank you.
Dr. Atri.
Yes, sir, we will start it. In fact, we received, when I took over as a principal, we received, I think, 6 months back, a mail from your institute regarding the nodal officer. And I have already appointed nodal officer at Jodi Medicine, Dr. B.N. Bogle is looking after. And we receive regular mails, as Dr. Cyril was saying. I have visited that institute twice. It's an institute of excellence. I think in many areas, it's even better than AIMS New Delhi. And we regularly receive these mails, like navigating CME and others, and we make a point to join them also. I remember we do join those CMEs, and mostly I think these are on weekends or on Tuesday. And we will start this process. We will, from other departments, 2-3 departments, we will make a cell and we will make it functional, because it's initiatives that will help us in promoting research in our institute, and definitely we will start it.
Very good. NAMS actually sets up collaboration with various institutions, national, international. For example, they have put collaboration with AIMS New Delhi. AIMS New Delhi is conducting this Navigate program. So, for example, some cardiac surgeon who has done work of international level, he becomes the faculty resource person, and that is done with Director AIMS and NAMS President. They inaugurate, and a CME of 1 hour or 1.5 hour runs on a particular day and particular time of the month. So similarly, AIMS also sets up, NAMS sets up task force, as Dr. Serene was saying. One task force has a AFMC Pune, and NAMS has set up a task force. For example, I am that is joint task force on high altitude medicine. So I am the person who is looking after task force on high altitude medicine. So we have actually started, we have given a white paper to government that what research should be done for people living in Ladakh, Kargil, and even the Sichuan glacier, and even the security forces and civilian population, what diseases they have. So this is very, we also included last time people who visit, come for yatra. They get high altitude pulmonary edema. We do not have any guideline and all. So how to treat them, how to do research in that area. So those type of task force are set in. So what Serin Sir was saying, even if any of us feel that there is a particular disease, particular area, your institution, your college wants to set up that task force. So you come forward with a proposal, we can have that joint proposal.
First of all, I congratulate for organizing such a wonderful and very sites that what is the future that we have to think about healthcare and medical education and research. Definitely, this is going to open a gateway for all the youngsters, whether they are the students here, say final year, and the new residents and young faculty. They should definitely try to see that what sort of help they can get from this academy, and they will get exposed to the initial, you can say, area of how to go for research, and that way they'll get much oriented for the future career making, as well as developing their own field or subject specialty can be continuous with. So at GMC Barabar, we definitely have this cell functional, and I'll also try to nominate the desired people who would take really positive initiative in this and will be very proactive in ensuring that we do enroll in this and we try to network.
Thank you. Professor Epat, we know that the government of India is trying to, because this 1.5 billion population, it has now recently overtaken China, and government is trying to expand colleges. You must have seen they have put a lot of effort on Ayush, because they think that you cannot make so many doctors rapidly, so that is a short way of circumventing the deficiencies. But while doing that procedure, expanding in theory colleges and making faculties and reducing the timelines for even the promotions, making a professor only in 7 years, they may say make professor in 3 years or something like that. That is fraught with risks of poor training and poor standard of patient care. So it might actually produce negative results. If you are not well skilled, well trained, you must have heard the WHO data of 2018 came that the patient care outside academia means college, research based, university based patient care. Outside academia has 2 to 2.5 risk of mortality and morbidity than what diseases would cause. So how do you think that this academy, whether at national level or even our UT level, how would we be able to put these checks and balances to maintain the standard of medical education in so many colleges which we have instituted now?
A very good morning to everyone. And at the outset, I would like to thank.
It is now good afternoon. I'm sorry you were engrossed in whole thing.
Yes, I'm sorry for that. So, very good afternoon to everyone. So, at the outset, I would like to congratulate Professor Sciences-SKIMS for initiating this principal's conclave. And at the same time, we got an opportunity to engage in this interactive section with the National Academy of Medical Sciences. The initiatives were put forth as highlighted by Professor Serene were very enlightening, and the initiatives that he suggested, like that the NAMS is doing, especially the leads in tribal fellowships and other initiatives that the Academy has for upscaling the skills of all the faculty is something that we should all look forward to. So that is one point discussion that we should enroll for NAMS and give it and make it an opportunity for the faculty and for the residents alike to get involved in it, so that their skills are upgraded. At the same time, I was just thinking as principal of the Government Unani College, Nandalpal, as you mentioned about Ayush and other initiative, are you including Unani faculty into this in NAMS?
Yes, there are even paramedical or initiative. Actually, this is the broader platform. But they're only seeing the credentials of an individual who can contribute to the academy.
What about nursing faculty?
Nursing faculty, I don't think if somebody has done extraordinary research, extraordinary contribution, it is not open. The application is such that it is reviewed by multiple committees.
Okay. So maybe the Unani faculty can be sensitized about this
Actually, how I came to know, I was a DM scholar and then I became faculty at AIMS New Delhi. I was going to see one uh, Dean of medicine who was chairman of medicine at AIMS New Delhi. His name was Jasbir Singh Bajaj. You must have heard of. He was treating diabetes of the former chief minister who was the leader here and who has started this institute, on whose name this institute is. So Dr. Jasbir Singh Bajaj was advising Sher Kashmir how to set up this institution. He has done everything. So I happened to be fortunately his treating physician in last days of his life. He himself was diabetic later on. So I saw him. He told me, I am president of this academy. The way Dr. Serene is there. You are so upcoming. Why don't you apply? So that is how I applied. My application went 3 times. So on after 3 years of scrutiny, every year they ask you what new work you have done, what papers you have published, and then they select you. I was probably, my teachers have got fellowship. Now I recommend their farm because I was very young that time. So they see what is your capability, what you have done. It is not bar that which faculty you belong.
Thank you. So we'll all work on it and start a notice.
Absolutely. Dr. Professor Roxana.
Good afternoon, everyone. It's like coming home back because long time back I was here for 9 years. And what I am here and what I understand is all because of skills. I owe a lot to this place because the Department of Anesthesia was at our excellence that time. So what I learned here, we could do the same thing in GMC Srinagar. And being principal of a very young medical college, the district hospitals which were converted into medical college 25 years back, and the peripheral medical college, we will try to inculcate what we have learned in skills. And as far as NMC is concerned, we do attend some seminars in the evenings. It's on first Tuesday of every month. And I would love if my younger doctors and we having their own professors within a span of 2 years. So they are all very good. We will nominate somebody for as a nodal officer, and we will create a research cell of NAMS, and we will try. And we should encourage these younger doctors. But before that, we will have to start NDMS. Unless we have NDMS, this cell has to, we will start this. And for starting MDMS, we should have our own professors. And within a span of 2 years, we'll have professors in various subjects. So we will do it surely and we will encourage our students and our professors. And I'm really glad that I'm having an institution where the faculty is very good, the residents are excellent, and the paramedic staff is very good. So very lucky that I got to a national medical college which is already doing a very good job, and they need our encouragement at all stages.
I would like to mention here, SKIMS also has one I am told in North India has developed a setup called Skill Lab. So we have Skill Lab and Simulation Center where you.
We do have it. I think in all medical colleges we
If you have I don't know, we will visit that cell also. If you think that it is better, that it can be connected again in the network and we can have similar skills and simulation programs for training.
We recently started DLS, ACLS on these labs on.
Yes, sir.
A very good afternoon to all, and thank you, sir, for making us wiser today on many aspects. Not only on the working of the medical colleges, but about these NAMS and other many aspects which have made us more wiser as compared to yesterday. Regarding GMC Rajouri, we are having a dedicated team of faculty members who are looking after the affairs of NAMS. We are conducting regular CMEs and we are making a point that they should attend online all the CMEs when they are announced. But I think now it's a time that I will direct them to coordinate with your nodal officer. So to have a better understanding and better benefit from NAMS for the students and for the faculty. And one thing I would also like to tell these students to make full use of the NAMS facilities like scholarship programs, and more emphasis now after coming to your place and attending your this CME. I'll be having now more stress on the various activities adopted by NAMS, and I will try to make my faculty as well as my students more aware about the work being done by NAMS, and I will guide them to take all the advantages from it. Thank you very much.
Very important because those colleges where infrastructure is in developing phase and they don't have about teaching and other, they can easily take the benefit from this. You just need to make some small IT system there, and you need to have a cell that you have a display board, you have some meeting arrangement, and that the things can actually transfer into their teaching and training. Good system.
Thank you very much, sir. We have basically, I was a pediatrician and we have a very strong association, Indian Academy of Pediatrics. We have more than 45,000 members and I am the first executive member from this group. So we are doing under that banner, we are doing regularly. We are doing TOTs, public outreach programs. Every year we do at least, which are sponsored by the Indian Academy. Now I have undergone metamorphosis, so possibly I will go to develop NAMS also. Surely with your support, we'll have a cell and we'll be regularly, I think, auditing programs soon once the activity being there. Thank you.
Thank you.
Good afternoon, everyone. First of all, I congratulate the organizing team and the organizer for organizing such an amazing event. I have to confirm whether dentistry people can be part of names or not. If yes, sir, then we are very fortunate enough. We would like to join the names so that our faculty and our residents can take advantage of this platform. So, sir, can we
Yes,
be part of?
yes. In fact, the last CME, AMS has an annual this CME. Last CME was done by my former colleague who was chief of CDER, that is Chief of Dental Education and Research of AMS New Delhi. His name is Dr. O.P. Kharvanda.
Yes, sir, we will
So
also.
he is an executive council member of NAMS and he did the program.
So, sir, we will coordinate with.
Yeah, he will be very happy. I will tell Dr. Kharvanda to actually support your colleges separately.
Yes, sir. Thank you, sir. Thank you so much.
Good afternoon, everybody. Dr. Ashok Ganai, sir, you have been instrumental in including two dental colleges, Srinagar and Jammu, in this wonderful enclave made what we have today.
After that,
If NAMS be included in our colleges, it will be a great help to our PG scholars, to our undergraduates and faculty. I assure you, GDC Srinagar will give you full support, will be nominated the nodal officer and provide a space for the research work. Thank you so much.
Thank you very much. So we should put hands together for all the colleges. Actually, we work sometimes in isolation. I would like to mention here also, when I came back from AMS New Delhi, I made a platform what is called Jammu Kashmir Ladakh Research Consortium. In that consortium that is bigger than this platform, where we have all universities and directorates also. There are 32 institutes of higher learning subservient in that. So what is that? Why I actually launched that consortium is that when we are engrossed in the era of super specialization, you take hand or you take eye or you take tooth and you think this is it, you forget the sister concerns. You do not know what is happening in developing in the sister branch, what is happening in biomedical research. So I was doing collaboration in diabetes with one of the institutions in Bangalore. I later on came to know that same biomedical instrument, insulin pump, was being developed by IIT Srinagar. I felt very bad. I felt stupid that I am doing collaboration with Bangalore. They have the facility here in Hazratbal. So sometimes you lose the sight of other concerns and we do not appreciate each other's efforts. So it is, we should have a broader palette for while we are diverging, where we are super specializing, we should converge also at some times to support each other and to have a coordinated, concerted effort towards development of research, medical science, innovations for betterment of human life. That is what is important. So this is, I think Professor Ashutosh wants to say something. Yes, sir, your comments.
Uh, Anything particular, sir, you want me to give my comments or in general, sir? Am I audible, sir?
Yes, you are.
Sir, my comments regarding the improvement of overall health scenario in Jammu and Kashmir state will be to use AI as much as possible, because today artificial intelligence is considered a remote thing. But considering the fact that the way it is coming, especially in diagnostics as well as in, let's talk of my field as in radiation oncology. Sir, in radiation oncology, we need to do a procedure called contouring. That means you have to contour all the organs, normal or those having cancers. It takes 3 to 4 hours for each contouring. And when humans are involved, a lot of mistakes occur, errors occur. We miss tumors, geographical misses are there. Now, AI is helping us in proper contouring as well as identifying the normal organs as well as the tumors. So it's easily available. Packages are not very expensive. So same thing about, I wish to strongly propagate that in radiology at least, we are doing all diagnosis will depend upon the treatment, upon the correct diagnosis. And if there is something, diagnoses are not done by our own doctors, so why don't we use AI packages, which are not very expensive, very easy to implement, very easy to purchase and implement also. So this is my strong suggestion that especially in remote areas, CT scan machines are available, but radiologists are not there. Similarly, second part is remote learning. Is we are starting hub and spoke model about ICU care. Government is very keen for pediatrics as well as adults. So when everyone is saying specialists are not available, why don't we use again the digitalization as well as technology to enhance ICU care by taking help of those centers which are already advanced in that, and then a hub and spoke model can contribute here also. So these are two strong suggestions which are easily implementable that will immediately improve our health scenario in the state, sir.
Thank you, sir.
Thank you. Thank you, sir, for introducing, organizing, and establishing NAMS at SKIMS. It shall really be a platform of Dr. Mithun J.
No.
It's not. GMC or the.
It's not online.
Is he there?
Not online.
So may I request Dr. Ijaz Malik, Professor and Head General Surgery and General Minimally Invasive Surgery, to say a few words about today.
Thank you very much. Good afternoon to everyone here at the August gathering of all the principals of our UT of J&K Ladakh. I'm really honored to be here as a coordinator of this NAMS CME today. I welcome everyone on board with a very nice subject of antibiotic stewardship, which every clinician, right from a pediatric clinician, right up to the top surgeons and physicians, everyone prescribing, unfortunately, I should say, antibiotics right and left. We should have a common policy of prescribing these antibiotics the way we should not do in this era, because if we become resistant to the antibiotics we are already having in market or available in institutions, we will be in trouble. The trouble will not be less than what COVID has shown us. It might be it might be a disaster to the entire world. So one has to introspect what type of drugs we are prescribing, what are the implications, what are the doses, which drugs to be used, which drugs not to be used, how should the ladder go. All will be spoken by three excellent lectures by the best faculty of the institute from 3 departments. We're going to formally introduce them. I thank you all. I would request now to have a formal felicitation of all the principals by our worthy director and ex-office secretary to government, Professor Ashraf Ganaisa.
May I request our worthy director, sir, to felicitate Dr. Ifat Hassan Shah, Principal and Dean, GMC Srinagar.
Can medical superintendent join me?
So please felicitate Dr. Ruby Rishi,
Can
Principal, GMC
Mohammed
Waterfront.
sir please join me? Next, Professor Ejaz.
Please felicitate Dr. Rusana Najib, Principal, GMC Anantnag.
He is the, I think anesthetists and surgeons are.
He has done a lot of work for institute, I tell you honestly, right from residency days. He has been very active.
Director, sir, may kindly felicitate Dr. Surinder K. Atri, Principal, GMC Kadrwa.
HOD medicine.
Director, sir, may please felicitate Dr. Amarjeet Singh Bhatia, Principal, GMC Rajouri.
Or HOD community medicine.
Director, sir, may kindly felicitate Dr. Rakesh Bahal, Principal, GMC Dora.
Dr. Buddha sir.
Director, sir, may kindly felicitate Dr. Khurshid Evani, Principal, GMC Handwara.
Myself, our plastic surgery.
Director, sir, may kindly felicitate Dr. Ejaz Ahmad Shah, Principal, Dean, GDC Srinagar.
Sir.
Director, sir, may kindly felicitate Dr. Parveen Elon, Principal, Dean, IGGDC, Jammu.
We have a guest, Dr. Ghulam Rasool Saab. Can you please join? Our senior pediatrician, I think everybody knows him. Yes, sir.
I thank all the dignitaries on dais for your valuable insights about the NAMs and SKIMS and UT of Jammu and Kashmir. Thank you. So today, So today's CME is focused to give us an insight about the growing menace of antimicrobial resistance and will stimulate us as healthcare providers for rational use of antibiotics. Trust me, we as internists are witnessing a murder of the concept of rational use of antibiotics. They are being used to misuse most of the times. So to begin with, I would like to invite Dr. Zubaida Rasool, who is a professor of pathology at Sher-e-Kashmir Institute of Medical Sciences, to give a formal introduction about the National Academy of Medical Sciences and its activities.
Good afternoon and welcome all. Since morning, a lot of deliberations and discussions have been going on about the NAMs. I'm pretty sure that everybody of us are very much well versed with NAMs now. I will be giving a brief description. I would like to recapitulate what I have been doing since morning, I have been talking about. So, about NAMs. NAMS, what we call it as National Academy of Medical Sciences. It's an acronym and it's a non-constitutional, non-statutory advisory body to the government in the matters related to the national health policy and planning, and acts as a promoting agency for continuing medical education for medical and health professionals. NAMS is a part of Inter-Academy Medical Panel, a global network of medical academies. It was established on 16 November 1961. The Academy started functioning when Jawaharlal Nehru, the then Prime Minister of India, inaugurated the institution on 19 December 1961. In 1962, the inaugural convocation was held at Vidya Bhavan, New Delhi, when Sarvapalli Radhakrishnan addressed the gathering. The Academy rebranded itself as the National Academy of Medical Sciences, India, on 16th December. Then who are the key people? The Academy is governed by a council that's made up of 22 Indian medical professionals from the medical community. Presently, NAMS is led by our president, Dr. Shiv Kumar Sari, and honorary secretary, Dr. Umesh Kapil, and treasurer, Dr. Rani Kumar. Now coming to the activities, the National Academy of Medical Sciences in India engaged in variety of activities aimed at advancing medical science, education, and healthcare. NAMS provides support for research projects and initiatives across various medical fields. The Academy published research findings and scientific papers through its journal, contributing to the global body of medical knowledge. NAMS organizes and hosts national and international conferences, seminars, and workshops to disseminate knowledge and facilitate professional development. Academy offers CME programs to help medical professionals to stay updated with the latest developments and practices in their fields. NAMS also provides recommendations and advice on health policies and practices to improve healthcare system in India. It collaborates with governmental and non-governmental organizations to shape health policies and standards. NAMS confers fellowships and memberships to distinguished professionals, and researchers who have made significant contributions to medical science. It awards individuals and institutions for their exemplary work in the field of medicine and healthcare. The Academy has instituted 6 annual awards for contributions in the field of research, service, publication, and academics. There are 6 awards. Dr. S.S. Mishra Memorial Award. The award is open to unpublished work in the field of biomedical science. Sir Memorial Award, awarded for the best unpublished work on community health and medicine, medical education, and hospital administration during a period of 3 years preceding the award. Dr. Vimla Yirmani Award, awarded for the work done in the field of physical and psychosociological rehabilitation of neurologically and mentally afflicted. Sriram Travel Fellowship Scheme is a fellowship open to faculty of an Indian education system for advanced learning at another Indian institute. Shamlal Saxena Memorial Award, awarded for the best work published or unpublished by a researcher in the field of biomedical engineering. Besides these awards, 2 annual orations, NAMS oration and Dr. K.L. Vig oration has been instituted by the Academy. NAMS also holds an annual conference called NAMSCon, which is a major event in the medical calendar. And latestly, in this year, it's to be organized in AIMS Jodhpur in the month of November. The Academy publishes a quarterly journal, the Annals of Medical National Academy of Medical Sciences, which provides a platform for researchers, educationists, and education administrators to publish their works. In SIKIMS, a dedicated NAMS central cell has been established latestly by the worthy director, Dr. Professor Ashraf Ganai Sahab. The cell will link SIKIMS with fraternities and institutions within and outside the nation, and we hope to learn a great deal of knowledge from it. Thank you.
Start. Shavir.
Thank you, Professor Zubeda, for your formal introduction about the NAMS. So without further delay, to chair this academic session, I would like to invite the chairpersons for the various presentations. First of all, I would like to invite Professor Ijaz Ahmed Malik, Professor and Head, Department of Minimal and Invasive Surgery, Kashmir Institute of Medical Sciences. Professor Sanaullah Shah, Head, Department of Internal Medicine. Professor Bashir Ahmed Fonda, Head, Department of Microbiology. Professor Anju Fazali, Head, Department of Community Medicine. Over to you, Chairperson.
Thank you very much. A very good afternoon to everyone. We're going to have now the actual program of NAMS. That is the Antimicrobial Stewardship. We have 3 lectures from 3 faculty members. The first talk will be talk on Antimicrobial Stewardship by Dr. Saeed Qadri, who is the additional professor in internal medicine skills. We would like to request him to come on the dais for this talk. The program is both online and offline mode, so there are so many people who are joining us offline also, the NAMS site also, so they will also distribute this site. Dr. Saeed Qadri.
Respected chairpersons and dear colleagues, good afternoon, everyone. So today we are here for a very important topic, that's antimicrobial resistance and antimicrobial stewardship. We have just gone through a pandemic of coronavirus, COVID-19, that came, devastated so many places, and then it's almost gone. But there is another pandemic that's going on, that is simmering, and that's a pandemic of antimicrobial resistance. Unless we do something now, it's very difficult what we are keeping as a reserve for the treatment of ailments of our future generations. So it's a topic which is very, very important. So what we are going to learn today, what are antimicrobials and antibiotics, what is antimicrobial resistance and how does it occur, inappropriate use of antimicrobials, how to control it, hospital antibiotic policy, and of course, antimicrobial stewardship, need of the hour. So what are antimicrobials and antibiotics? Antimicrobials are the agents that kill microorganisms or stop their growth. They can be antibiotics, antivirals, antifungals, antiparasitics. But in general terminology, whenever we talk of antimicrobials, we usually talk of antibiotics. So antibiotics are the most important weapons for the treatment of many infectious diseases caused by bacteria. Antimicrobial resistance occurs when microorganisms change over a period of time and no longer respond to antibiotics or antifungals, making it difficult to treat and get rid of the infection, increasing the risk of its spread as well. Multi-drug resistant organisms are those that are resistant to multiple drugs and are very difficult to treat, increasing the morbidity and mortality due to infections caused by such resistant organisms. So an infection, a bacteria enters a human body, it multiplies, we give an antibiotic, the bacteria die. But in case a drug-resistant bacteria enters a human body, it multiplies, we give antibiotics, it does not respond, and the person continues to be sick or even can die. So these are some MDR, multi-drug resistant organisms that we must have heard of. Every now and then we hear of these organisms: VRE, vancomycin resistant enterococci, methicillin resistant Staph aureus, MRSA. We hear about it quite often. ESBLs, extended spectrum beta lactamase producing gram-negative bacteria, carbapenem resistant enterobacteriaceae, CRE, or carbapenem resistant Pseudomonas, MDR-TB, resistance to at least INH and rifampicin, that we call MDR-TB. So what is the impact of resistance? What happens by drug resistance? So there is excess length of stay in the hospital or healthcare facility. These drug-resistant organisms, they interfere with the patient's normal flora. These infections become untreatable. There are increased side effects because we have to give higher antibiotics, we have to give higher doses. So the side effects increase, and there are financial outcomes, the costs increase, cost of treatment increases. Then ultimately what happens, this all leads to selection of drug-resistant organisms that thrive in an environment, especially environment of the hospitals, tertiary care centers. And ultimately it leads to increased morbidity and may lead to mortality as well. What are the causes of increasing AMR? It can be intrinsic, where you can do nothing. The cause is natural. Penicillins attack cell wall, and the organisms which don't have cell wall, so penicillins cannot help there. Protease species is intrinsically resistant to polymyxin B because of that lipid layer, which is in its cell membrane. So it is intrinsically resistant. The other part is acquired resistance, where the organisms develop mutations, DNA genetic mutations over a period of time, they evolve, or sometimes there will be a gene transfer. For example, a plasmid gene, a susceptible bacteria comes in contact with another bacteria which has a plasmid, gets transferred, and this bacteria also becomes drug resistant. And why these things are happening? These are happening because of inappropriate use of antibiotics. There is misuse, there is overuse, and then there is underuse. So what is misuse? Using antibiotics where they are not recommended. For example, viral infections. We see these days also, we see a lot of viral infections, upper respiratory symptoms, and people start taking OTC antibiotics, over-the-counter antibiotics, and we should discourage it. Superficial skin infections. For example, somebody has a superficial abscess, you just need to drain it, maybe a local antiseptic dressings or maybe local ointment. No systemic antibiotic should be given. The other misuse is using an antibiotic which is not effective against the expected agent or syndrome. For example, using anti-streptococcal antibiotic for community-acquired pneumonia. We have to understand that it is very unlikely that staph is the organism responsible for community-acquired pneumonia. Usually we don't see staph there. So we should not put anti-staph in these patients. Using an antibiotic that is resistant to the expected organism confirmed by the hospital antibiogram. For example, levofloxacin is very commonly we see it's being given in urinary tract infections. But our hospital antibiogram shows good amount of resistance to levofloxacin of E. coli. So we should discourage this practice. The other part is overuse of antibiotics, like using multiple antibiotics where a single antibiotic may have been enough, or indiscriminate use of high-end antibiotics where even a first or second generation antibiotic could have been enough. So no antibiotic de-escalation from broad to specific coverage. Now, suppose we have started a patient on multiple antibiotics. Now we get a culture positive or molecular test comes positive. Then we have to re-escalate. We have to stop the other antibiotics which are not to be given. But what we see many times, de-escalation does not occur, and we continue to give these broad-spectrum antibiotics for a longer period of time. And using antibiotics for longer than recommended duration. Suppose the recommended duration for treatment of cystitis is 3 days. We are giving for 10 days. We are giving the organism chance to develop resistance. Underuse, very rarely, but yes, it can be an important cause of antimicrobial resistance. Inadequate dosage of a drug that is suitable for an agent. Suppose an agent requires 1 gram of a drug, we are giving only 500 mg. So what's happening? It's a perfect environment for that organism to fight against that antibiotic and develop resistance. Ultimately, even 1 gram will not be effective. So dosage has to be precise. Shorter duration of prescribed antibiotics of choice. So a drug, there we were previously we were discussing about the longer duration. Here, a drug, suppose, needs to be given for 2 weeks. We are giving only for 5 days or 3 days. Again, the antimicrobial has been killed, but inadequately, it will again emerge. And this time it may emerge as a resistant organism. So shorter duration should be avoided. And delay in starting an antibiotic where it's needed. Yes, we have an indication to start antibiotic in a patient. If we delay, the organisms can be overwhelming, and then the drug may not be effective. And in fact, the resistant strains can emerge. So what are the causes of AMR broadly? Antimicrobial resistance, what are the causes? Lack of awareness. A lot of people, a lot of healthcare workers, a lot of doctors do not know about the problem of antimicrobial resistance. They keep on prescribing drugs like anything. Then inappropriate use of antibiotics, as we just discussed. Inadequate diagnostic capacity of many hospitals, like at many places, not just hospitals, at many areas. So a patient gets fever, so they don't have the testing capacity to diagnose this fever. Those say they start empirically that patient on a drug. For example, in our part of the world, starting patient on typhoid treatment. Every patient says, I have typhoid, I have typhoid, I have typhoid. Whether it was a viral fever or something else, we don't know, because that area or that hospital did not have that capacity to do that diagnostic test. So that also leads to inappropriate use of antibiotics. Then limitation of recent AMR data. So how do we develop an antibiotic policy? We need to have an AMR data as we have in our hospital. Every year, our microbiology department, it uploads the latest antibiogram of the hospital. So we have a data that what are the organisms that we have in our hospital and which are resistant and what drugs they are sensitive to. So once we know this data, we can be better in giving the antibiotics. So if there's a limitation to this data, I don't think other hospitals are having such kind of an activity going on. So limitation of this also increases the possibility of giving resistance. On the other side, if we see the other part of it is insufficient infection control practice in the hospitals. This can lead to increase in spread of these MDR organisms and increase in resistance. Absence of proper surveillance systems. We have to have surveillance where these organisms are coming from, which are the areas which we have to zero in and restrict. Then improper management of sanitation and waste. So if the waste stays there, these organisms thrive there. Again, that can be a cause for increasing resistance. And common to both these arms, whether we talk of hospital or we talk of individuals giving antibiotics, is the financial resources. If they're insufficient, a patient may not be able to continue the antibiotic course, may stop in between, giving a chance for resistance to occur. Or if the hospitals do not have financial support, they may not get proper surveillance systems, proper management of sanitation and waste. So we have these financial resources have to be there. So preventing emergence of multi-resistant organisms in a healthcare setting, like our hospital. So there are some core preventive measures like standard precautions, contact precautions that's prevent spread of these infections from one person to another, one patient to another, doctor to patient, doctor to doctor, and then to another patient. Then we have to have surveillance, we have to have decolonization. Then the other part is environmental preventive measures like cleaning and disinfection, preventing understaffing, reducing overcrowding. And the third and the important one that we are discussing today is to rationalize antimicrobial usage. So this is what we're focusing today. So how to rationalize antimicrobial usage in a hospital healthcare setting? So for this, we have a hospital antibiotic policy that we have made in our hospital. So to make a hospital antibiotic policy, it's a multidisciplinary team that's required to develop and regularly update the hospital antibiotic policy as per the evolving hospital antibiogram. So we need clinicians from different fields, from medical fields, from surgical fields. We need lab people, especially we need microbiologists, we need pharmacists, nurses. There has to be an antibiotic committee, an infection control committee. Then we can think of making a hospital antibiotic policy. So what are the components? How is hospital antibiotic policy made? It's made based on common diseases, common organisms in the community and their resistance patterns, common organisms in the hospital, acquired infections and their resistance patterns, and of course, the hospital antibiogram, as I already discussed. So we'll discuss something about hospital antibiogram, then we'll come back to hospital antibiotic policy. So hospital antibiogram of SKIMS, let me show you our hospital antibiogram, how it looks like, how to find it. So we go to the website of our institute, the SKIMS website, scroll down. Here on the left lower corner, we see this is the microbiology antibiogram, and we see it's being updated every year. 2020, 21, 22, 2023 is the last one. And based on this, once we click that antibiogram, we can download it and we can see the details. And this is how it looks like. So this is the first page of the antibiogram. This is one of the inside pages. I just put it here to show it to you. So we can see the red boxes. These are the ones which are resistant. On top, we can see the antibiotic line. On the left side, we can see the organisms. Staphylococcus, Staphylococcus pons, Enterococcus species. So what we see here, that most of the staphylococci, they are sensitive to vancomycin and linezolid. Enterococcus has some resistance to vancomycin and gentamicin. So this antibiogram tells us about what are our bugs, what are our pathogens, and what is their sensitivity and resistance patterns. So we have to first identify the clinical syndrome once we are treating, keeping in mind the antibiogram. Suppose it's a respiratory tract infection or a urinary tract infection or enteric fever or brucellosis. Then we think about the probable pathogen and the local resistance pattern. For example, we talk of UTI, the common pathogen is E. coli, and it is nitrofurantoin sensitive. So we don't need to give high antibiotics. A simple oral nitrofurantoin may be good enough, only once we know all the background. So what are the aims of, coming back to the hospital antibiotic policy, what are the aims of hospital antibiotic policy? So we want to reduce the morbidity and mortality due to antimicrobial resistance in hospitalized patients, preserve the effectiveness of antimicrobial agents in the treatment and prevention of communicable diseases, provide uniform guidance for use of antimicrobial agents for treatment and prophylaxis. So what are the objectives of antibiotic policy? Objectively, we want to guide for empirical therapy, prescribing strategies optimized as per the clinical syndrome or suspected organisms. We want to guide about the specific therapy, selection of antimicrobial agent for specific organism, guidelines for prophylaxis, especially in cases of elective surgeries, dose and route of administration, IV, oral, or some other route, duration and timing of antibiotic therapy to maximize clinical cure or prevention of infection, whilst limiting the unintended consequences of antibiotic use, including drug toxicity. The policy must incorporate specific recommendations for the treatment of different high-risk special groups, such as immunocompromised hosts, hospital-acquired infections, and community-associated infections. So this is how our policy looks like, hospital antibiotic policy of SKIMS. This was developed in January, the last December, January. And this is the contents leaflet showing the various contents, introduction, guidelines, rationale of antimicrobial prescribing, surgical prophylaxis. Then chapter 2 is empirical antibiotic guidelines for adults, respiratory tract infections, sepsis, septic shock, GI and intra-abdominal infections, so on, so on. This is one of the inside pages, like respiratory tract infections. So you can see at the top acute rhinosinusitis. So the organisms, it's written 90 to 98% it's viruses, so we don't need to give antibiotics. And in the comment section, you can see the criteria to consider antibiotics. Persistent, more than 10 days without improvement, worsening, 3 to 4 days of worsening, fever more than 38 degrees centigrade, facial, tooth pain, antibiotics given only if this criteria are met. So this is how directions are given for each and every problem. So this is empirical antibiotic therapy for sepsis and septic shock of unknown origin. So we can see a patient comes to the emergency with sepsis or septic shock. The first thing we try to see whether the patient has risk factors for resistant organism. So what are the risk factors? A patient who's hospitalized for in the previous 90 days, a patient coming from long-term hemodialysis, a patient who is immunosuppressed, a patient who has received broad-spectrum antibiotics in the last 90 days, non-Hodgkin's lymphomas, nursing homes or long-term healthcare centers, known MDR organisms in the past, concern for Pseudomonas. If these things are there, then we go for high-end antibiotics like piptazole or meropenem or vancomycin. And we may add atypical coverage if we think patient has a community-acquired pneumonia. If these things are not there, we just need to go simply to ceftriaxone, first-line antibiotic. And if we think of staph infection, we can give vancomycin as well. And optional is, of course, atypical coverage. If we think patient has a community-acquired pneumonia or anaerobic, then we give metronidazole. Here, I want to stress that we should avoid quinolones. Quinolones, we should only give if there is penicillin allergy, because India is a high endemic zone for tuberculosis, and quinolones are antitubercular drugs. We should not give them empirically. Somebody who's working in a particular area. So what is the way ahead to take care of all these things? The way ahead is antimicrobial stewardship. So what is antimicrobial stewardship? Antimicrobial stewardship is coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of optimal antimicrobial drug regimen, dose, duration of therapy, and route of administration. So what are the steps to control irrational drug use? So making the right clinical diagnosis, whether it's infectious or it's non-infectious, like viral versus bacterial, or limiting empirical antibiotic therapy to genuinely seriously ill patients, that too after taking an appropriate culture. So if the patient is genuinely very sick, then only we should try to give empirical therapy, like in patients who have febrile neutropenia, who have severe sepsis or septic shock, who have community-acquired pneumonia, who have ventilator-associated pneumonia, or necrotizing fasciitis. Otherwise, we should wait for the cultures for the organism to be found out. So we need to choose the appropriate antibiotic, use the correct dose, route, and duration of therapy with adequate tissue penetration at the site of infection. For example, UTI, E. coli is good enough, but we have to understand that nitrofurantoin loses effectiveness once EGFR falls to less than 60, and some people say less than 45. If a patient we have a patient who has a UTI, we think it's E. coli, but at the same time, his EGFR is lesser than 45. So their NFT may not be helpful. This we have to keep in mind. So another very important point in antimicrobial stewardship is de-escalation or modification of therapy. So when do we modify therapy? We modify empirical broad-spectrum antibiotics depend on culture antimicrobial susceptibility reports and patient status. We should stop polymyxins and glycopeptides if no carbapenem resistant organism or MRSA is identified on cultures. We should go back to these antibiotics and stop polymyxin and glycopeptides. Avoid using double or redundant gram-negative or anaerobic coverage. Many times we give double gram-negative coverage, which is not required there. Or we add anaerobic coverage unnecessarily when it's not required. Discontinue antibiotics if a non-infectious mimic is identified. So suppose a patient is very sick, and at the outset we have started the patient on antibiotics because patient had sepsis, or maybe the patient was in shock. But the sooner we identify that it was a non-infectious mimic, maybe it was vasculitis, maybe it was a viral infection. So we should try to stop antibiotics and treat in the right direction. So the other part is de-escalation. De-escalate combination therapy to a single agent. So in the beginning, a patient who comes with sepsis, septic shock, we give gram-negative, gram-positive, and sometimes even we give anaerobic cover. But once we get the culture, maybe next day we get the culture, and nowadays in today's times we get cultures, we get organisms in 2 hours. So once we get the cultures or we get the organisms, we need to de-escalate. So from combination, we should change from broad spectrum antibiotic to a narrow spectrum one. We should change from IV to orals. We can change from IV to, these are all part of de-escalation. De-escalation is safe in all patients, including febrile neutropenia and septic shock, and reduces mortality and length of hospital stay. So we should not give antibiotics in the following clinical situations: respiratory tract viral syndromes, which I think is one of the areas where antibiotics are most misused. That happened in COVID, and it's happening right now also. We're going through that phase of climate change, weather change, and we are seeing a lot of upper respiratory infections. So we don't give antibiotics in viral pharyngitis, viral sinusitis, viral bronchitis, or non-infectious cardiopulmonary syndromes like heart failure, LVF, pseudotumor. So we don't give antibiotics there in these situations. So no antibiotics in the following clinical situations like skin and soft tissue infections. Subcutaneous abscess need to be drained. Maybe local antiseptic, local dressings, or maybe a local ointment, antibiotic ointment, but no systemic antibiotics. Lower extremity stasis dermatitis doesn't need antibiotics. Asymptomatic bacteriuria and pyuria, including in those who are catheterized, should not be put on antibiotics. Microbial colonization and culture contamination should not be started on antibiotics. And low-grade fevers can be monitored till we get the diagnosis without putting them on antibiotics. So we have to reduce or optimize the duration of therapy. Like community-acquired pneumonia, 5 days of therapy, antibiotic therapy is good enough. We don't need to give more than this. Hospital-acquired pneumonias, 8 days are good enough. Skin and soft tissue infections, 5 days are enough. UTIs, if it's a cystitis, 3 to 5 days are good enough. If it's a pyelonephritis, 5 to 14 days of antibiotic therapy we should give. Catheter-associated infections, 7 days are good enough. Staphylococcal aureus bacteremia, if there is low risk, there is no risk of complications, 2 weeks are more than enough. If there's high risk of complications like in infective endocarditis or empyemas, there we give up to 6 weeks. Intra-abdominal infections, 4 to 7 days are good enough. Surgical and antibiotic prophylaxis, single dose is good enough. So what are hurdles to AMSP? So logistic hurdles are like lack of awareness regarding AMSP and rational use of antimicrobials. This needs to be increased. Lack of proper antimicrobial stewardship team or committees in the hospitals. Lack of proper hospital antibiotic policy. I don't think any other hospital in the UT of JK has a hospital antibiotic policy. Lack of coordination between treating departments. This is a very important thing that will be discussed in further slides. So there's a problem of inertia, another hurdle to AMSP. So there's a lack of inertia, problem of inertia, inability to break inertia to send cultures, blood and site-specific before starting a patient on antibiotics. Many times we don't send cultures, we just think, oh yeah, it's this infection, let me treat it. And once the patient does not respond, then we start sending cultures, and the yield definitely is low once we have already started the patient on antibiotics. So we have to break this inertia. We have to send cultures before starting the patient on antibiotics and before we change or modify the treatment. On many occasions, there's an inability to overcome the inertia of not involving other departments from the outset at the right time. And this is a problem. We may not acknowledge it, but this is a problem. We often get calls from other departments after 3 weeks, 4 weeks, kindly advise. And in our advice, we do add this line, please involve us from the beginning or at the right time to take care of this infection. A good part of this inertia, very, very important. A good part of this inertia is the inability to overcome the ego, to call someone else from other department to discuss or decide the treatment of your patient. And this happens a lot with the people who are working in the labs. Clinicians, they find it difficult to listen, to understand, and we have to address this problem. We cannot shy away. So the way forward, how to tackle these problems, how to take care of these problems. So we have to put in some steps. One can be prescription audit and corrective measures, like identifying the problem areas by observing the prescriptions in an area of the hospital, for example, a ward or an ICU facility, to see the pattern of antimicrobial prescription, goes with the norms or not with the norms, and then take corrective actions. And in case anyone wants to get a consultation or opinion for antimicrobial regimen for his patient, the MSP team should always be there to guide and it should be done well in time. Many clinicians follow their own way of initiating and modifying antibiotic regimen for their patients directed by their own experience and knowledge. It's very important to have a uniform system for the whole hospital, however knowledgeable we are, and the community at large. That needs to be followed by everyone with checks and balances like the post-prescription audit, so that the mistakes can be identified and corrected on time, and also person informed and educated about the protocol by the AMSP team. So correction or pre-authorization is another method. Different levels of clinicians prescribe different levels of antibiotics. For example, senior consultant from the respective department should be consulted. It means his permission should be sought before starting a patient on high-end antibiotic. Or if a clinician wants to initiate a regimen of high-end antibiotics, he should fill up a form to justify its use. And it's been found these practices do help in reducing misuse. AMSP team should be consulted before putting a patient on high antibiotics. The other step can be formulary restriction. Restricting the hospital formulary and high antibiotics to be issued only when the prescription form is signed by a senior consultant or a member of the AMSP team. This step is slightly not possible in our hospital, because if we want to put in this step, the formulary has to have all the drugs, because the patients do have access to the market. So this may not be fully effective, but whatever, we should start from somewhere. Cultures. It should be made mandatory to send cultures before initiating a patient on antimicrobial therapy, or whenever escalation or modification of antibiotic regimen is sought. So de-escalation, again, few words. This is to be done especially in patients, critical or non-critical, who are put on empirical broad-spectrum antimicrobial therapy involving one or more high-end antibiotics after the causative organism is identified by cultures or by other methods. Here we taper the therapy from broad to narrow. We may stop few antibiotics. For example, a patient has been started on 3 antibiotics, as I just said a while ago, and now we see patient has a staph aureus infection. Stop gram-negative coverage, stop anaerobic coverage, and only focus down to gram-positive coverage. We can even switch from IV to oral formulations of stopping the antimicrobials completely. So this is the last slide. I think this, the WHO aware classification, every clinician should be aware of. The name aware itself says, so this tells us which antibiotics to write, which we shall have free access, which antibiotics which we should keep in watch list, prescribe them occasionally, and which other antibiotics we should try to keep in reserve, prescribe them very rarely. So there's a list. Anyone can Google this WHO aware list and have that downloaded in their mobiles, and whenever you want to prescribe an antibiotic, please go through the list and do accordingly. So antimicrobial stewardship is a responsibility of everyone. The administrator's role is to provide logistic support. The physician's role is to prescribe antibiotics following local policy and seek specialist advice wherever required. Microbiologist's role provide antibiograms and critical insights into the various infections. Nurse's role is to administer antibiotics properly, safely, and in a timely manner with prompt review and therapeutic drug monitoring and adverse reaction monitoring. And pharmacist's role is ensure antibiotics are prescribed as per policy, provide prompt review and advice on therapeutic drug monitoring results. Thank you. Thanks for a patient listening.
Thank you for doing this, and I think this was a very, very informative, and I think it covered all the things what we should know and which we should follow. But this lecture has not come just within a week. There was a lot of effort put in from last so many months to a year. Things were gathered and collected, data was collected, and then came these all recommendations and the booklet which has been formed. So I think we hope that all the clinicians will follow these all guidelines in letter and spirit. That will be the only message from this lecture. But before going to the second lecture, I want to ask from the audience if they have any questions.
First of all, I would like to congratulate you for a nice lecture. It was a surprise to me that we have a hospital antibiotic policy. I would suggest it should be circulated among the faculty members so that it is available to know.
There's a plan to release it maybe in the coming days, maybe a couple of weeks. We'll release it, and then it will be circulated.
Nice presentation. Well, acknowledged. The only thing I think I have missed is you have not talked about over counter drugs. And you like you over the counter. What about that?
So that talk is coming. So AMSP in the community.
I think in the community we have a resistance
Yeah.
because of over the counter.
Absolutely.
There should be restricted at community level. No prescription drug should be used, even others, but particularly, you can get antibiotic for those guys from my talk.
It's an excellent point. It's an excellent point Dr. Munir has raised, and we'll have a talk on this by Dr. Javed. Basically, I was trying to cover the healthcare facility area, and I just touched the OTC part once I was talking about formulary restriction. We cannot restrict because the drugs are available OTC, and that is one of the causes. Ma'am.
So at the end, in your last slide, you said you depicted the responsibilities of the stakeholders in it, and at the top you mentioned about the administrators. So it's not only the keeping the logistics of it. That's not the only role of the administrator, because as you know, that irrational prescribing of drugs that needs to have actually a regulating mechanism which can be put in place by the hospital administrators. I'll give you an example of the prescription audits. Actually, the prescription audits are going back to put things in place. Improve our prescribing practices, and not only improve our prescribing practices. Before we go for audit, I think I personally feel that we need to sensitize our prescribing. That includes each one of us, because at the end of the day, each one of us is a prescriber. So we need to be actually aware about the good prescribing or the appropriate prescribing practices which have been actually laid down by WHO has given guidelines, Ministry of Health and Family Welfare has given guidelines, and against those guidelines, the prescription audit is being conducted, and it is importantly aware that we do a prescription audit, say in the first quarter of the year, then after in the next quarter we reassess, because in the first quarter we try to find out the gaps and the lacunae, and we try to put things, remedial measures in place. And then we do a re-audit in the second quarter, and at quarterly intervals, then we actually find a visible change in our prescribing practice. I think that is the role of the administrator.
Well said, ma'am. Basically, I'm running a project, ICR funded project, AMSP. So there we are doing it. Actually, what you are saying, it is being applied in some areas of the hospital. We are covering almost around 200 beds. So we are doing this audits, monthly audits we are doing. And I present the data, around 8 months data, in the ex-directors in the meeting, in the boardroom. And we could see the change in the practice. We could see that change. Everyone appreciated there, seeing the graphs, how they were coming down. So your point is very much valid. We need to put it in the bigger picture, in the bigger field, first of all in the hospital, then in the community. Very well, sir.
Yes. I want to ask that whether it can put any restrictions on the use of some class of antibiotics like carbapenem, polymyxin, and how do you actually implement those restrictions?
Right now, there are no restrictions. There are. It's a kind of it's a thing which is understood that before putting a higher antibiotic, we need to be sure. But there are no black and white restrictions, and we need to reach there. We need to make black and white restrictions. That is the purpose this antibiotic policy is coming up. We have to establish AMSP practices here, and for that we have to start either these audits, filling up the forms. Before anybody starts high antibiotic, he should give the reason. So just thinking about giving the reason, he may stop prescribing, at least for that patient. So that will save us one patient, one organism maybe at a time.
One more request I have, that this antibiotic policy should also be available online.
Yeah, basically, I'll tell you something.
This will help the centers like ours who don't have.
Basically, antibiotic policies, once I was making it, there were some guys, some people, senior people who were telling me, how do we know that this antibiotic policy you have not taken from somewhere? So we have to understand it that antibiotic policy cannot be taken from somewhere. It has to be customized as per every hospital, as per the antibiogram. So we cannot have X hospital's policy applied to our hospital. We have to talk to our microbiologists. They are always in touch with us. Our microbiologists, they have been very helpful. In consultation with them, in consultation with the antibiogram, we see which organisms are active, which are resistant. As per that, we make our antibiotic products.
But in centers that are close to.
Yes. I agree. Your point is very much valid. The things that we see here, it's very much possible. Similar things are happening around us, at least in the UT of Kashmir, JK. So we can spread it literally to the hospitals, and they can take guidance. Absolutely, point taken.
Yes, sir, it was a nice presentation. But I want to say, like, it is in hands of clinician to implement policy.
Absolutely.
And of course, administrator. And this is the situation, like, with our principal and director, they didn't listen to this. Most important.
This was really discouraging.
From above downwards, like, if they are not paying interest, it will never happen.
So the effort that was put in, I agree with your point, sir. It was discouraging.
They tried to stay back, but they went. So that's why these things are not happening, because it's basically implementation, nothing else. It's all theory, I know, everybody knows. But we have to implement these things. But we are not implementing. That's the problem.
So,
regarding restricted antibiotic, I made a list in Dr. Shaukat Zargar's site. Restricted antibiotic list was posted on the website, and one of the consultants from your department medicine, he said, now there are some mistakes and there are something.
Mistakes will be there.
We have to improve on this.
Nothing is perfect.
We have to learn from each other. We have to work in. We cannot work in isolation. We have to work together. Like, this is very important topic. And next pandemic, people say it will be because of AMR. So even this, people they predict that it's already there. So we have to take these things seriously. Like, there's no medicine resistant or very less microbial resistant. You are there. There's nobody to listen to these things. So these things, because the first they go waste like this. So we have to. I suggest that this topic should need to be discussed again.
Sometime, maybe in the grand round. Just for the information of the house, I was introduced to MSP by Professor Famda only. So he is the one who brought me to this topic. And this topic is very close to my heart. And I was really so happy that 10, 11 principals, big people are here, and they will take some message and start at their own hospitals. And it was really discouraging seeing them leave without listening to the
I want to say that everybody is being mistaken, whether it's me, you, or anybody else. So everybody is being mistaken in this usage of antibiotics. So we should rectify ourselves, starting from ourselves, and then should be brought into the whole.
Sir, I just want to make a point to microbiology team, or to make some, to me also. Any patient who is admitted in SKIMS, either elective or through emergency, is on 1 or 2 antibiotics. Sometimes the critical patient is on 3 or 4 antibiotics. Before giving the first dose of antibiotic, ideally we should take the cultures in A only, but sometimes it doesn't happen. Or a patient who is referred from periphery has already received multiple antibiotics. So in such cases, the yield of cultures, it is never 100%. It is 40 to 60% in good centers. So initially we get many cultures, they are sterile, and we are giving antibiotics to and high-end antibiotics. Is there any method to improve the yield of cultures? Like if we mention the patient is already on ceftriaxone or vancomycin, does it help really to a microbiologist? Or we should make it sure the patient received first, we should take the cultures.
If you're a patient and you want to take culture testing, that you do before you start it. Most of the situations, the antibiotics are already there. So one thing is that you can take the culture when the next dose is, when the drug level is very low. No, newer methods or molecular methods are available. So in molecular method, there is no, even if the patient is on antibiotics. So we are also improving in those areas, advancing in those areas. So you can do molecular detection of these resistant bacteria by doing molecular methods. These are a few things, but culture really should have been taken. Now the initiative is being taken, the emergency lab is being upgraded, and we have suggested that if it's possible that the facility for microbiology, we need just an incubator and just an incubator to keep the culture there. So you have taken the emergency, just keep there and send it to the one. So I hope that these things will grow by as and ask.
I think we have a lot of questions, but Dr. Ijaz will be the last to speak because we have time constraints.
Now there's time constraint one surgeon is coming. You see, I have felt always there are big fallacies in antibiotic usage. Let me just have corrected just one minute. Why shouldn't a hospital have a hospital antibiotic policy? What is the reason? Why are we day in, day out, रात को, शाम को, सुबह, दिन को, बाहर निकलते, antibiotic policy क्यों नहीं है? Why? What is the reason? Are there agencies behind this?
No.
Are there some drug prescribers behind this? Are there some these MRs behind this? Yes, we have to introspect.
Sir, the biggest problem that, because I'm into it, I can explain to you.
Okay.
The biggest problem is who will belt the cat. So I have made a policy because it was very close to my heart and I was doing a project. It was a requirement. And I told you a policy needs multidisciplinary approach. It needs clinicians, most of the departments, almost all departments, then microbiologists, then pharmacists. So here, who made it? I had to do it myself.
Absolutely.
Yes, I did. I definitely consulted various departments.
दूसरी बात, what I have found, I think the biggest change जो है ना antibiotic prescription में, एक clinician जो लिखता है ना उसमें ना, antibiograms will not work. Hospital policies will not work. If there is a clear-cut indication of simple ufloxacin for a particular problem, why are you prescribing carbapenem?
Sir, you're very right, sir.
Drilling is available. I'm sorry to name this. And here you have a amoxicillin, some combination. Easy to use, more broad spectrum, and it is a class of drug which is not higher. If you have resistance, you can use other drugs. Simple measure, but we do not follow.
You're very right, sir.
Also culprits.
You're very right, sir. We at SKIMS are in a position where we can be a guiding light. So that is the chance that we have to use. That's what I was thinking today.
We are using antibiotic prophylaxis for most of the surgical operations. And believe me, there is just 3 doses of antibiotics we use even for major surgical procedures. 1. Number 2, there are some surgical procedures where antibiotic usage is not to be used at all. For example, a simple breast abscess drainage, a perianal fistula drainage. There are so many breast or other abscesses in the body which can be drained nicely. You need to have daily dressing and wash. Antibiotic is just, I can say, an eye wash. Another thing is that why public on, what is the problem? I go to Delhi, if I have to get an antibiotic, I tell you honestly, several times, I have made a prescription by a doctor in Srinagar, and he has done a WhatsApp. I have taken a printout, then gone to the pharmacist and told him that give me these drugs. Because even if I tell him that I am a doctor, he says, no, I want a prescription. Now, I'm not having prescription in my pocket. Now, if there is so much strict policy of getting a simple drug, this does not conform to anti-anxiolytics and drugs which can be used tomorrow, some form of those addicting drugs. Simple antibiotics you cannot get. Why can't that policy be formulated by our state government? What is the reason? And one more thing, surgeons and intensive care specialists. These are people who are being always looked down upon by great physicians. I'm sorry to say that we misuse drugs. But it is the circumstances that make that so happen. For example, intensive care. How many times you clean those pipes and other things of a ventilator? Don't you think hospital-acquired pneumonia, hospital-acquired infections are a big hazard to our community? I have found it myself. Patient coming here, getting treatment and dying here. Never going home. It's not about all. Not because of primary infection or primary illness due to which he was admitted. No.
Secondly,
he
hospital-acquired infection.
Yes, died because of hospital-acquired. I think all these aspects are to be seen, made an introspection, and then some form of policy to be done. Not at the, it should be right at the village level, where from first pharmacist starts, husband should assign, medicina pentathlon, Tislasama, medicina following. Why should this happen?
His expert comments. I think we go to the next topic. And the next topic will be from the antibiotic diagnostics stewardship, which will be presented by the Professor Gulnaz from the Department of Microbiology. Professor Gulnaz, please.
Good afternoon, everybody, respected chairpersons and my dear colleagues. The topic assigned to me is microbiological diagnostic stewardship. My presentation, it is divided into two halves. In the first half, I'll focus mainly on the understanding of the diagnostic stewardship. And the second half will be on the sample collection procedures. First, I'll start with the definition. It is the process of modifying the ordering, performing, or reporting of diagnostic tests to improve the diagnosis of and treatment of infections and other conditions. The famous 4 T's of diagnostic stewardship, they include ordering the right tests for the right type of patient or the right type of sample, collected at the right time in order to guide treatment decision. So what are the objectives? The primary objectives, with the highest priority being given to improvement of patient care and outcomes by promoting accurate and timely diagnosis, avoiding patient harm, and optimizing the antimicrobial use. In turn, there are some secondary benefits, and they are improving the efficiency of care in the hospital, reducing the overall costs, and improving the institutional metrics related to the healthcare-associated infection. Historically, diagnostic stewardship was a laboratory activity that focused on optimizing specimen collection, processing, and reporting to ensure accurate test results and interpretation. But more recently, there has been an increasing understanding that test results can strongly influence antimicrobial utilization. For example, up to 80% of hospitalized patients with asymptomatic bacteriuria are inappropriately treated with antibiotics. So, diagnostic stewardship, it has evolved into a process of quality improvement, utilizing multidisciplinary teams led by healthcare epidemiologists, clinical and medical microbiologists, and personnel who deal with antibiotic stewardship. The other stakeholders are physicians, surgeons, pharmacists, nurses, and infection preventionists. So all these stakeholders, they can play a role in optimizing the test use, and they should be involved in the development and implementation of diagnostic stewardship initiatives. Traditionally, it focused on inpatients, but now it has been expanded to include other settings like ambulatory and long-term care setting. For example, depending on the patient population, the test can be optimized. Like we can optimize testing for group A streptococcus. It may be a priority for ambulatory patients, whereas urine cultures and C. difficile testing, it may be more relevant in nursing homes. Pre-test probability versus diagnostic stewardship. There are some terms which we need to understand before we go ahead with this. And one of them is pre-test probability. And awareness among clinicians and understanding of pre-test probability of infection is essential for designing diagnostic stewardship interventions that improve the usefulness of tests. Many diagnostic stewardship interventions, they function by increasing the test use in high-value settings with high probability of the disease. For example, where there's a probability, like in patients of meningitis, there's a high probability of having positive blood cultures. And discouraging or blocking tests in low-value settings, where there's a low probability of disease and greater potential for false positive results, which may result in patient harm. Example being taking blood cultures for cases of cystitis. Then there are many times when microbiological testing is inappropriately being done. The most common type of inappropriate testing is over-testing, which can lead to diagnostic errors in the form of overdiagnosis, unnecessary antimicrobial treatment, and excessive cost. A misdiagnosed infection. In many of my slides, you'll see examples because these examples, they will help you to understand various terms. A misdiagnosed infection, for example, attributing mental status changes to UTI, can cause delays in treatment or missing the true diagnosis, which may have serious negative consequences for the patient. For example, mental status changes were attributed to UTI when it was actually due to a stroke. Another less frequent form, as Dr. Mudassir said, is underuse of testing and potentially a missed diagnosis. There are many examples of inappropriate test use, like routine ordering of microbiological tests when specimens are obtained for non-infectious indication. Patient did not have any indication of an infection, but the doctor said, yes, for the sake of it, let us send it for microbiological testing also. This leads to overdiagnosis, treatment of contaminants, and colonizing organisms. There is excess cost, increased length of stay, because now the contaminant has come as the result of culture. Now the patient has to stay in the hospital. There is then you have to reconfirm that the test is now negative. So all this leads to overdiagnosis. Then, as far as there is another thing that without any reason, preoperatively, urine is being sent for cultures. Again, this leads to unnecessary antibiotic prescribing. Same is true for urine and respiratory tests for test of cure or for asymptomatic cases. This leads to missing the true reason for the presenting symptom. As I already described in my previous slide, that urine cultures for change of mental status when the patient does not have any symptoms, or the lab analysis of UTI, again, this can lead to misdiagnosis with the patient having something else and you are attributing it to UTI. Then there is another inappropriate use is when a patient is on laxatives and you are ordering a test for detection of C. difficile. This leads to overdiagnosis and unnecessary antibiotic prescribing. Then there is one more test, that is the beta-D-glucan. Some clinicians, because of ignorance, they do not know that beta-D-glucan does not detect mucormycosis. So if it comes negative and patient is still having mucormycosis, he will be inadequately treated and it can ultimately lead to his demise. Then you have recurring blood cultures in patients with known cause of fever. A patient you know already has a cause of fever and you are sending the cultures again and again. What is the fun of it? It leads to unnecessary antibiotic usage, patient discomfort, unnecessary procedures, and even healthcare associated anemia because of so many draws of blood. Then the procedure of single blood culture, taking single blood for culture in adults, this is practiced in our hospitals and all the hospitals across the state most of the times. Again, this can lead to a misdiagnosis because you need to take a minimum of 2 sets and each set contains 2 blood cultures. One is aerobic and another is anaerobic. And if you do not take the sample properly, it can lead to inadequate antimicrobial management, overdiagnosis. That means you are treating contaminants, because if a single culture grows cons, you'll start the patient on treatment and it will lead to, again, missing the true pathogen. Then same is true for superficial wound swabs for culture. We are getting swabs day in and day out. There is no mention on the forms what it is from, and it has not been collected properly. Many a times we grow contaminant and commensal organisms, and our clinicians, they put the patient on treatment. So again, leading to missed and overdiagnosis. Then another case is of routine use of SARS-CoV-2 PCR to determine the duration of isolation, which should not be done. So in this slide, I'll be talking about the conceptual model of diagnostic stewardship. and various interventions at different steps in the diagnostic pathway. As you can see on the top, it is the clinician who is at the beginning and at the end of this diagnostic pathway. It is the clinician who on the basis of the pre-test probability decides which test to be ordered, sends the sample is transported to the laboratory. All this is the pre-analytical part of testing. Then it is followed by the sample being received in the lab for testing, and this is the analytical part, followed by the reporting. And finally, when the report reaches the clinician, he has to interpret these reports and decide what to be done with the patient, whether to put him on antibiotics or not. I'll be discussing each of these in detail. The first and foremost thing before ordering a test is that the clinician, he must understand the test performance characteristics which he is ordering, like the sensitivity and specificity of the test, and he has to estimate the pre-test probability, because the probability can be low, it can be intermediate, or it can be high. So these estimates are made on the basis of incidence of a disease or on the basis of the specific population. Like it can be a healthy person in that the probability of the disease is different as compared to people who are immunocompromised or teens of age. Similarly, the clinician need to know the risk factors, which is expressed as likelihood ratio, which the risk factors which increase or decrease the probability of a particular disease. The example being inappropriate ordering of urine cultures in elderly patients. It often identifies asymptomatic bacteriuria. Many elderly people, they have asymptomatic bacteriuria and they do not have UTI. But if we inappropriately order urine culture in them, it leads to a positive culture and subsequently inappropriate treatment with antibiotics. The second most important thing is test ordering. In our setup, test ordering is done on a form, on a case sheet. But the best way is to have an ordering by an electronic health record. Why? Because it allows for numerous interventions to improve the test utilization. Before a clinician, he enters his order, the test order, many a times the electronic health record, it can prompt him it can inform him regarding the alerts on the utilization of the test. Or it will first ask him for the indications why he is ordering the test. He cannot move forward unless he enters the indication. Then this electronic test record, it can create menus, making the test more or less orderable. For example, there can be a hard stop. If a person is on laxatives and the clinician wants his stool to be tested for C. difficile, he cannot place that order because there is already a stop in that. So electronic health record system is the best way, and for this we need a stout IT department in the hospital. Then comes our part, that is the analytical phase, and diagnostic stewardship can be improved in our lab also. This can be new diagnostic methods that shorten the time to positivity, which can improve the appropriate or an appropriate therapy can be given to the patient. We can have improved diagnostic methods which have better sensitivity to a wider range of pathogens. Like we can have various panels or multiplex panels we can have for viruses, bacteria, the parasites and others. The lab can form algorithms to optimize the predictive ability of a test, such as lab can perform sequential, conditional or reflexive testing. What do we mean by that? The lab can perform urine cultures only when urine analysis is abnormal. That means it's a stop there. They will not move forward. That sample will be rejected and it will not be tested if the urine analysis is normal. Testing only if certain criteria are met. Once we get a respiratory sample and we find that on culture we grow only respiratory flora. In that case, we do not go further, we do not speciate and we stop there and write the culture shows growth of respiratory flora, no further thing is to be done. Another very important thing is selective testing which is a very important part of this diagnostic stewardship. What is this? It is the practice of not performing susceptibility testing for inappropriate situations, such as positive cultures for organisms suspected of being contaminant. If one of the two blood culture sets grows coagulase negative staphylococcus, it is a contaminant. We will not put susceptibility in this situation. Then comes the reporting and the post-analytical phase. This can again be optimized in many ways to help clinicians to make more meaningful interpretation of test results and take appropriate therapeutic decisions. Again, as I said, as far as respiratory cultures are concerned, if we grow yeast in them, we will write yeast grown rather than Candida species, so that the clinician does not treat these because they are most of the times as contaminants in the respiratory tract. Then in reporting, the microbiologists, they can mention causes of false negative and false positive results, which will again help the clinician in making timely decisions. Again, we will not result interpretation that this is likely a contaminant. It again can help the clinician to take decisions, and the microbiologist on the basis of culture results can even recommend the therapy. Then there are some terms which everybody, clinicians, microbiologists, and all the healthcare personnel should know. Like, as I already said, that comments we can put at the time of reporting. Then ease of ordering. The ordering, it may be difficult, or it may be easy, or we can remove a test if we feel that it is not, that it should not be included in a particular panel, or we can include a test. For example, we may include blood cultures in sepsis panel. Then there are stops. Stops can be soft stops. That means a clinician can override and he can order that test, or they can be hard stops. That means he is not allowed to move forward and order this test. Reflex testing, as I already said, that if we do not have urine analysis report, we may not culture that sample. Then selective testing is, again, I said, as contaminants, we will not process them further. Then there is a term called selective reporting, only reporting part of the result. For example, if we are doing a respiratory culture, we can suppress daptomycin susceptibility in such case, so that it is not being used in that situation. Another term is cascade reporting. What is cascade reporting? It is a stepwise reporting. That means you suppress the results of broad spectrum antibiotics if the sensitivity is there for other antibiotics, and you give the results of only narrow spectrum antibiotics. Then another term is result suppression. Result suppression means, like in urine sample, you have multiple organisms. And it's not a must for the microbiologist to mention the name of all. He may not release the species name of those organisms. In addition to all this, we need to adhere to monitoring the best practices. Like, we can go for quality indicators like blood culture contamination rates. What are the blood culture contamination rates? That will tell us about how properly the samples are being taken. And then is the feedback. Then comes the clinician interpretation. For correct interpretation of test results, the clinician should be able to assess how well a test identifies patients who have a disease and who do not have a disease. Sometimes the clinicians have a poor understanding of test performance. For example, many a times they will try to treat urine and respiratory culture results rather than UTI specific or pneumonia specific symptoms. For post-test interpretation, online diagnostic calculators are available, like Testing Wisely. They can help estimate post-test probabilities of the disease. Blood, urine, respiratory samples, and C. difficile testing, these 4 samples are the focus of antimicrobial stewardship program. Why? Because blood cultures, they form one of the most commonly ordered microbiological tests in hospitalized patients. They have a low positivity, but a high risk of false positive results. All over the world, about half of all the positive blood cultures, they represent contaminants. A significant number of blood cultures are collected as single or with inappropriate blood volume. Again, if you are inappropriately testing, it may overestimate central line associated bloodstream infection. Same is true for urine cultures. Again, false positivity is high. Same is true for respiratory cultures, especially in patients with comorbidity, in intensive units and tracheostomy, where they most of the times represent colonization. And again, as far as C. difficile testing, it is inappropriately ordered in patients who are already diagnosed and they are already on treatment. And if you ask for the testing again and again, it will give you wrong results. So what are the targets for the diagnostic stewardship for these common microbiological tests? First and foremost is blood cultures. Avoid routine use for non-septic patients with low risk of bacteremia. Avoid daily blood cultures for febrile patients with negative blood cultures and no clinical changes. As one of our faculty members, he said, they do not grow anything. The patient is already on antibiotics. You do not expect them to grow. As Dr. Bashir said, the main thing is that you should first take the sample in the casualty. They should be sensitized. That take the sample first and then put the patient on antibiotic, or take the sample before the next dose of antibiotic. That is the best way as of now. In addition to that, our newer systems, blood culture systems, they do have mechanisms where they neutralize some of the antibiotics, but despite that, the yield will always be low. And as far as molecular tests are concerned, they will never tell you whether the patient is cured or he is still having the infection, because they can even pick up dead bacteria. So that way, again, they cannot help you to prognosticate. So for collection, decontaminate the skin prior to blood draw, ensure optimal volume and optimal number of blood cultures. Avoid taking blood from central line. Then in our laboratory, we can help by having rapid pathogen identification. Yes. Well, again, for respiratory cultures, I'll talk about these in my, just one thing. Yes. I'll be talking about the specimen collection. We have to consider differential diagnosis, decide on the test to be conducted, and decide on the clinical samples to be collected to conduct these tests. There should always be a consultation between microbiologists and the clinicians. Correct sample for correct report. Appropriate sample should be collected properly, transported properly, and you should always distinguish between viral and bacterial infection. Bacterial culture must be collected prior to antimicrobial therapy in the correct container by a trained staff, transported within 2 hours. Blood and CSF, they should never be refrigerated. All samples, they should be accompanied by completely filled request form, which is rarely the case in our hospital. Contaminated cultures, as we already said, they can lead to unnecessary utilization of resources, increased hospital stay, unnecessary antimicrobial use, and unnecessary additional patient care measures and profound cost. We have to differentiate between colonization and infection, as I already said, because colonizers, most of the times, they are harmless. But if you take a proper sample of CSF, blood, pleural fluid, which are from normally sterile sites, you take care of the skin decontamination, then these are the true invaders. But from sputum, from wound, many a times they are colonizers, and you have to take precautions in collecting the sample. Blood, we have to, as I already said, 2 sets are to be taken. Paired blood sample should be taken. The doctor should wear a gloves, disinfect the venipuncture site with 70% alcohol, followed by tincture iodine. Then wipe the top of the bottle and inoculate it into the bottle. 1 ml of blood for every 10 ml of culture media. Usually 5 to 10 ml is enough to inoculate the bottle. They should be transported immediately, but if not, you can keep it at room temperature till it reaches the laboratory. For CSF, you know how it is to be collected, but aseptic precaution using sterile needle, sterile stylet, and you have to collect it in 3 sterile tubes. 1 for chemistry and serology is the first tube, 2nd for culture and sensitivity, and 3rd for hematological study. Please do not collect CSF and keep it in your refrigerator for 10 days and send it after 10 days for microbiological analysis, which many a times we have seen being done in this hospital. Never refrigerate, and if delay is expected, store at room temperature or in the incubator. Again, the same is true for sterile body fluids. Disinfect the skin. As for blood, send 1 to 5 ml of aspirated material, but please do not keep the needles on in the syringes, swabs are not a good sample. Urine, as all of you know, this is the commonest sample we receive, but it is the most abused sample, not properly sent. Please instruct the patient. Send the sample in a wide mouth container. Ask males and females to wash their hands, use soap and water to clean the part. And after passing the urine, the initial portion sent as the midstream sample, 2 to 5 ml is enough, and transport within 2 hours. This can be refrigerated if delay is expected. For catheterized patients, this is very important. You have to clamp the catheter, and above the clamp, you have to disinfect the catheter and collect 5 to 10 ml with a needle and syringe. Never collect urine from the urine collection bag, or by disconnecting the catheter from the tube of the urine collection bag. This will most of the times give you wrong results and false positive results. For suprapubic aspiration to be done in infants and comatose patients, again, decontaminate the skin. Urine is aspirated in a sterile container. Then you have a throat swab, especially in cases of pharyngitis where they suspect bacterial pharyngitis. You hold the tongue with a tongue depressor. Then with 2 swabs, you then for the throat, you have to use 2 swabs. You
Please make it on here.
for respiratory samples, you should wear a PPE and then collect. For nasopharyngeal swab, the head is to be tilted and the swab inserted into the nostril. Leave it in place for a few seconds, and after rotating, it can be taken out and placed in the transport medium. Same is true for the nasopharyngeal aspirate. If you want to send respiratory samples outside, you have to follow the triple packaging system for transport, with the primary culture in the container. Then you have the secondary and the tertiary container, which is labeled with a biohazard label. For sputum, a wide mouth container. Ask the patient to preferably collect it early morning after rinsing his mouth, but before brushing. Then take a deep breath and cough deeply. After that, it should be sputum and not saliva, which is watery. Never send endotracheal tips or suction tips for culture. These cannot be. Sputum can be refrigerated except if Streptococcus pneumoniae or H. influenzae is suspected. Endotracheal aspirate, it is to be done using a sterile 22-inch 12 French suction catheter. The first aspirate is discarded and the second aspirate is collected after tracheal installation of 5 ml saline. If very little secretion is produced, chest vibration is used to increase the retrieved volume. Send the specimen to the laboratory as soon as possible. Same is true for bronchoalveolar lavage. Stool, it can be in the form of liquid stool, or 1 gram of stool sample can be sent. If delay is expected, then transport medium can be used, and form stool is unacceptable for C. difficile. As far as pus is concerned, open wounds, they should be first debrided, followed by thorough cleansing with sterile saline prior to collection of sample. Then the biopsy or curette sample is sent from the base or the advancing margin. Formalin should never be used for culture. For closed wounds, disinfect the area and aspirate the pus with a sterile needle, a sterile syringe. The same is true for genital swabs. Then we have some sample rejection criteria, which include incorrect containers, broken, poorly sealed or leaking containers, unlabeled specimen or mismatch between sample requisition form and container, unacceptable delay between specimen collection and arrival at the laboratory, sample which is stored incorrectly before or during transport, or samples in formalin, inadequate quantity of specimen or a dried sample, 24-hour urine or sputum collections are not acceptable. Poly's catheter tips and endotracheal tips are not acceptable. Same is true for urine from bag of a catheterized patient. Follow-up cultures are at times indicated. We have rapid tests which differentiate between bacterial and viral, like procalcitonin and C-reactive protein. We have rapid tests like antigen detection tests in urine, in throat, antigen detection for malaria, leishmania, dengue. We have multiplex PCR tests or syndromic panels for respiratory, gastrointestinal, and meningitis and encephalitis, which can help us to give the reports fast. Then we have another panel, which is a BCID panel, which can help in rapid identification of blood isolates. Same is true for MALDI-TOF. If we get a positive blood culture, you can immediately put it, subject it to MALDI-TOF, and you will get the result within 1 hour. Then next generation sequencing, its application is yet to be seen in the clinical field. So finally, the patient, once he comes and he's suspected of having an infection, we have various samples which we can send. We can have serum for antigen or antibody detection. We can subject him to the biomarker testing to rule out bacterial infections, or we can send samples for rapid tests, microscopy, or appropriate cultures. And initially, we can give a preliminary report. If the blood culture gives a positive flag, we can give the report of gram staining, followed by culture identification and AST, and the final report can be given to the patient. The source is the SHIA position paper and NAP AMR module for prescribers 2024. Thank you so much.
Thank you very much for this presentation. I think there's no doubt that the Department of Microbiology is doing a commendable job, has been doing a commendable job. And they give you the right track on which you have to treat any infection in the body. And the way you have shown how to take different cultures, what to do, what not to do is very important, especially for the resident staff, because they are the pillars in the hospital who work day in, day out and do these things. It's really a good insight she has put on. Pretty much with them.
Congratulate you on presentation of an important aspect, that is the diagnostic stewardship, an important part of the antibiotics. As you know that the infection prevention and control practices, they also form an important component of the antimicrobial stewardship. I would like to know from you as a microbiologist, to what extent do the existing infection prevention control practices in our institute affect or interfere with your diagnostic
The infection prevention control.
Has she presented some data for that? Or
I just want to get an idea. This is an important determinant of, as you yourself said, the right diagnosis is very important for prescribing the right drug, and that actually is what microbial stewardship is about, right? So, making the right diagnosis yourself said that at times we do give the contaminants to affect actually the diagnosis of the.
Actually, what is very
in your practice, how many such cases have you come across where it is actually the contaminant and not the real?
Many a times we have seen this, and this is being seen all over the world. That whenever, like as I described in the pus collection, that is one of the clinical where the clinicians are very poor at collecting. I'm sorry for that, but maybe it is the poor understanding of the thing. The surgical site infection, again, in many wards, we see that we grow cones in them. So what is the reason for that? Reason is that they think that once they remove the dressing, immediately the swab is to be taken and sent to the microbiology lab. They do not understand that it is actually, you have to rinse it with normal saline, clean it, then take the deeper part, take the biopsy tissue or the deeper pus from inside. That is the true representative of the true infection. So there are many such instances, especially in blood cultures. All over the world, it is seen that poor preparation of the line or the vein, it leads to contaminants growing in the blood cultures. And that again is people are to be educated, and continuous education is to be done.
Absolutely right. I think the right way, I can give you a suggestion for that.
Yes.
See, people ask me suggestions, I always. It is better to send your residential staff to the wards.
So we do not have that much of staff that they can go to every ward.
To take samples.
Okay,
No,
sir.
not
Okay.
for that.
Yes, for teaching purposes.
Yes.
Yes, sir. Why not? We are always there. We can do it.
For teaching purpose, not for putting you on CBC. They can direct our resident, they are their brother or sister. They can direct them what is the right way of taking a culture. What is the right way of collecting a swab?
Yes.
What is the right way of transporting a particular tissue to microbiology for assessment? These are things which have to be surgical resident which are ज़्यादा कुछ नहीं देखता है जो अपने senior को देखता है करते हो वही करता है.
True.
But please don't. सर्जन्स को तो सब करते हैं ना. मैं यहाँ देख रहा हूँ मुझे पता है फिजिशियंस और बाकी क्या करते हैं. आप मुझे एक बार बताओ प्रिजम्पटिव डायग्नोसिस 2024 पे आज कल भी मैं क्या मेरे सर्जन हजरात देते हैं एंटी एनारोबिक ट्रीटमेंट. Why aren't you keeping a facility for anaerobic culture? What's the reason? I requested your HOD
So we have
to procure some
many a times
instrument. Although
asked.
it is austere and is available only in few places in India. But there are so many things which we are having which no one else has in North India. So you should procure
So
it.
we have many a times we have asked for it, but we never got it.
And number two, one more important. If a cultural sensitivity is being sent to you, I'll give you a practical example for that. If a cultural sensitivity is being sent to you, most of the times the discs available जो है वहाँ मैं जानता हूँ, सब डिस्क वालों को भी जानता हूँ, डिस्कों को भी जानता हूँ, और कल्चर्स हो जाते हैं. ये सिंपल ड्रग्स के साथ आप कल्चर क्यों नहीं करते?
Sir, हम वही करते हैं. So, but they are most of the times. No. Most of the times they are.
I'll tell you honestly.
Sir, most of the times they are resistant. Sir, I want to share something with you, sir.
Okay.
So recently we published a paper of one of our PGs that was properly done study on UTI.
Fine.
Sir, it is so alarming to
The
see.
nitrofurantoin is the drug of choice.
It is. But sir, we got in 95% we got MDR. MDR in 95% of UTIs we got MDR.
This is unfortunate.
Isn't it, sir?
But what is the teaching going on?
Drugs क्या दें?
What is the teaching going on to my resident? जो मेरे साथ पीजी कर रहा है, कल को जा रहा है बाजार में, फर्स्ट चॉइस ऑफ ड्रग लिखता है, वो फेनोल नहीं लिखेगा, वो ट्राइमोक्सोल नहीं लिखेगा, डाइसाइक्लिन नहीं लिखेगा, एमोक्सिलिन नहीं लिखेगा, सीधा नाइट्रोफुरांटोइन लिखेगा.
So it's okay. Why not? It's okay, sir. He should because it's a simple antibiotic and we are not taking
I'll tell you an
much
example.
resistance
No,
in
let
nitrogen.
me tell you an example. Ulta. For example, there is a mesh infection or some wound infection. I have seen it practically in my OPD. They are resistant to all forms of drugs that are available in the market. And ultimately, I have found that a cotrimoxazole or tetracycline works for a period of 1 week and infection goes off and there is complete healing. This has happened to breast, this has happened to perineum, this has happened to abdomen. Practical examples I'm giving you.
Sir,
In that time,
one
there is
thing
no
regarding
antibiotic which has not been given by private practitioners, allied specialists.
So the main thing is that the sample is not being collected properly because many a times you send those samples which grow colonizers and they are multi-drug resistant. So please tell your residents to collect the sample properly after proper rinsing it so that we can get. No issue, sir, but they should be prepared to listen to us. That is important. Yes.
Yes, I think it's not only surgeons, don't be, and I get this.
It's for everybody.
And we are doing it. But my suggestion would be that you should every quarterly have a programs of teaching people in the auditorium, I think, so that everybody, you cannot go to every ward and every time. And
Sir, actually, NMC wants there's a module for AMR on prescribers module on AMR, which has been published by NMC, and we have a cell, a NAP AMR cell in SKIM. Sir, we have been told to take almost classes from the faculty to the junior resident.
Exactly.
We have to teach everybody, all the prescribers, on all these things. This is part of that. This is part of
This
that.
is what I was telling.
So this will be repeated many a times in the hospital in coming months.
Best thing is repeated and
Yes, sir. It will be. It will
to the bigger the audience, which covers all the departments. That's one.
Yes.
Send them to wards to each people.
No issues, sir.
Last I request is that please send the MIC reviews which we need.
Sir, we are doing MIC only for blood, and that is not. Our Dr. Bashir will answer this, sir.
Also to Ajaz, like antibiotic, every time we present this antibiotic resistance in this half, people say that you are not testing those on syndrome and absolute. It's not like that. We are following CLSI guidelines. For each syndrome, like for each organism, they have a specific guidelines that this antibiotic will be tested. But I don't know why they don't say, please just show me one prescription and we can discuss it. There's no issue. I will discuss only in this auditorium, but we don't discuss in day-to-day routine. If so, you have a question like you want that this antibiotic was not tested, please send it to the department. We do it. Why not? Well, it's not. That's not a problem. That's it. That's a standard procedure we are following. Secondly,
MIC.
like MIC only for blood culture. MIC for blood culture. That's a better, not for person. Then that would be more expensive. We don't have that system that every isolate we have to check on that. Whatever. Do a manual MIC, which is.
Thank you, sir.
Thank you, Dr. Nag.
Thank you very much. Thanks a lot.
I want to answer Dr. Ajaz was saying that some old antibiotics like nitric acid. We are seeing that if we don't use an antibiotic for 5 years, initially it was resistant, but after 5 years of not being used, it again become.
I was talking about the pillars under integrated antimicrobial stewardship uh, program. Now, the third pillar of this integrated antimicrobial stewardship is regulate and social triggers and remuneration policies that promote the responsible antimicrobial prescription and dispensing behaviors. Now, health workers who are prescribing antimicrobials and dispensing behavior can often be determined or influenced by systemic factors that may be outside the immediate control of health workers. Now, these systemic factors could be the bacterial status and the concentration of the drugs, then this gut gut flora, and it might be also serum effect of the drugs. They are all included in the systemic factors. At institutional and facility levels, mechanisms are needed to reduce the amount of antimicrobial being inappropriately prescribed, dispensed, and administered. There needs to be legislation and regulation responsible and appropriate use of disposal of antimicrobials. Now, some of the audience, among the audience, one has raised the query on that there should be a legal enforcement for the sale of over-the-counter drugs. Now, there must be enforced legal and regulatory instrument frameworks at every step in the life cycle of antimicrobials, starting from the research and development and at the prescribing level, at the dispensing and administration level. So all levels of antimicrobial life cycle should be regulated, and there must be legal framework. Now, the fourth pillar is improve awareness and engagement to support behavior change in the use of antimicrobials. Now, this can be achieved through improving awareness and understanding of antimicrobial resistance through effective communication, education, and training, and target different audiences using communication and behavior change strategy. Include within schools curricula the appropriate use of antimicrobial agents, infection prevention and control, and drug-resistant infections. Engage with communities and families to take local actions. Now, actions and consideration include support the design and implementation studies to understand level of awareness and determinants of behavior, conduct regular and continuous awareness and engagement creation campaigns on threat of drug resistant infections and measures to contain them, and organize, coordinate highly visible, regular national advocacy activities such as during World Antimicrobial Week. We must be aware about this Antimicrobial Week. Every year, we observe Antimicrobial Awareness Week in the month of November. Now, integrate tailored AMS message into broader national health promotion, prevention, and treatment rehabilitative initiatives. Then we need to develop tools and conduct a regular assessment and evaluation of impact of education and awareness campaigns, establish and maintain a national knowledge management hub, develop educational toolkits and materials to improve knowledge and practice, develop joint communication strategies with stakeholders in other sectors, produce documentaries, testimonials, impact stories based on individual affected by drug-resistant infections using One Health approach, conduct regular surveys and analysis to understand knowledge, attitude, and behavior towards antimicrobial use and resistance. Now, the fifth pillar is strengthen health worker capacity through provision of tailored education and training packages according to health worker roles and functions. To ensure the understanding and awareness among the health workers, it is important to make AMR, antimicrobial resistance, a core component of undergraduate and postgraduate professional education. In service training and certification courses, other continuing education programs in human health, veterinary, and agriculture practice sectors. Now, competency-based training in antimicrobial stewardship requires effective engagement of students, active professionals, decision makers, and other professional groups. Educational intervention should address the needs of recipient health workers according to national and subnational context. Educational intervention should be sustainable, pragmatic, timely, high quality, cost effective, relevant, and efficient. And the next pillar is enhance WASH in health facility and community. WASH stands for water, sanitation, and hygiene facilities in the health sector and in the community. Now, WASH and safe waste management complements antimicrobial stewardship activity by reducing incidence of infection and need of antimicrobials. If we prevent infections at the first instance, then we do not require any antibiotics. So this is the rationale behind this WASH and safe management. Now, reducing the release of excreted resistant genes and antimicrobial compounds and their metabolites. This is one of the driving force for antimicrobial resistance in the community. It is important to ensure safely managed wash and waste management facility and implementation of effective evidence-based interventions and practices to prevent infection. Now, in low and middle income countries, 40% of the healthcare facilities do not have a reliable water supply, and 19% do not have adequate sanitation, and 35% do not have hand hygiene facilities. Globally, every year, we treat millions of cases of diarrhea with antibiotics. And knowing the fact that 2 billion people use a contaminated drinking water, which is the source of and which is the reason for these diarrheal cases. And 2 billion people still do not have basic sanitation. And we are treating them with antibiotics. We are not addressing the source of problem. We are not addressing the source of infection. And excreta and wastewater from 60% of the population are not safely managed. Safe wash in communities can avoid 60% of wash-related antibiotic use. So we can, by providing wash facilities, we can at least avoid 60% of use of antibiotics. Thereby, we reduce the chance of antimicrobial resistance. Then implement IPC core components in health facilities, because we know if we do not follow infection prevention control facilities in the healthcare sector, so we cannot control hospital-acquired infections, which are more liable to have this antimicrobial resistance. And same antimicrobial resistance strains are then they go into the community. And there is an emergence of this antimicrobial strains in the community. So if we want to implement antimicrobial stewardship in the community, one of the important component is implementation of infection prevention control practices in the hospitals. Now, to improve the quality of care and prevent the emergence and transmission of drug-resistant infections, proper IPC intervention should be in place. IPC, WASH, and antimicrobial stewardship activities are interdependent, and they require coordinated efforts towards a resilient health system and infrastructure to tackle antimicrobial resistance efficiently. The WHO core component for effective IPC programs should be promoted, including multimodal approaches for their implementation. National authorities can start identifying areas of improvement by using available assessment tools that allow gathering data for a situational analysis. All health workers should be. Okay, sir. Now, vaccination services also play an important role in preventing infection and minimizing the use of antimicrobials. Now, the last pillar of this integrated antimicrobial stewardship is surveillance of antimicrobial use and consumption, which includes monitoring and evaluation of antimicrobial stewardship activity. This is the common pillar. There must be documentation and reporting of antimicrobial use and consumption, uh, uh, which will help to relate the exposure of antimicrobials with the development of antimicrobial resistance, early warnings of problem relating to monitoring shortage or stock outs of antimicrobials, monitoring outcomes of intervention, assessing quality of prescribing against practice guidelines, and raising awareness. Now, methodology for monitoring of antimicrobial use and consumption vary according to monitoring objectives and maturity of surveillance system. Regular monitoring, regular measurement and sharing of consumption information to prescribers and policymakers are the first step in increasing the awareness and importance of optimal antimicrobial use. Now, surveillance of antimicrobial resistance. Now, drug resistance surveillance is essential to inform planning and implementation of integrated antimicrobial stewardship activity. National authorities may fulfill this requirement through building laboratory capacity, standardization of methodology, internal and external quality assurance, and participation in GLASS and other established surveillance systems. Then monitoring and evaluation, which is included in this surveillance of antimicrobial resistance. Regular monitoring and evaluation help to assess the quality and effectiveness, coverage, and delivery of integrated antimicrobial stewardship activity and to make necessary adjustment. Implementing internationally agreed standardized indicators for AMS activity and establishing standardized national reporting and recording formats to capture these indicators are essential. Now, internationally agreed indicators for integrated AMS activity in human health include total human consumption of antibiotics for systemic use in defined drug doses per thousand population. Then second indicator is proportion of excess antibiotics for systemic use relative to total antibiotic consumption in defined drug doses. Relative proportion of aware, which is excess watch and reserve for pediatric formulation, and percentage of hospital patients, adult pediatrics receiving antibiotics according to aware categories. Now, there are other indicators that is percentage of human health facilities that have core set of relevant essential antibiotics available and affordable on sustainable basis, percentage of inpatient surgical procedures with appropriate timing and duration of surgical antimicrobial prophylaxis, presence of legislation and or regulation requiring that antimicrobials are only dispensed with prescription from an authorized health worker. National authorities should make resources available and evaluate the capacity in implementing these indicators, and also introduce other optional process and outcome indicators based on the development of health infrastructure and their national context to facilitate the implementation, monitoring, evaluation of integrated antimicrobial stewardship. Now, the last but not the least, the take-home message is antimicrobial stewardship is a critical strategy in combating the growing threat of antimicrobial resistance, both globally and within India. In the community setting, effective antimicrobial stewardship requires a multifaceted approach involving healthcare providers, public health system, policymakers, and patients alike. By integrating evidence-based policy, promoting judicious use of antibiotics, enhancing infection prevention and control, and addressing barriers to implementation, we can safeguard the efficacy of antibiotics for future generation. Thank you. Thank you.
Unfortunately, audience were very less important. That is what is going on.
Already on 171 crore.
That's great. Yeah.
It will go to.
They're still online.
Can watch.
They're still online.
Yes.
It was good, very good presentation, and you rightly said that the multi-modal approach is required for stewardship. It's not only the human, but veterinarian and environmental. So we always use a blame game that medicine people will say that veterinarians are using antibiotics. Veterinarians, they say the physicians are using antibiotics. And those agriculture people, they say that both of them are using antibiotics. So this blame game we have to leave and we have to work together as a team. So unless we control in all these three sectors, we won't be able to have a resistance control system. So very nice presentation.
Dr. Amit, I would like to add a few things since your topic was antimicrobial stewardship in the community. So, in the present era of us, taking the concept of One Health, so it is not only the appropriate use of antibiotics in humans, it's appropriate use of antibiotics in humans as well as animals, right? Yes. So, as we, Dr. Bashir was saying that the veterinarians are responsible, equally responsible. Yes, so, that is one aspect of it, that treating animals and treating humans, we are using antibiotics. Yes, but one important aspect I would like to add to it is that unknowingly, all of us, the community as a whole, is being exposed to antimicrobials without knowing, and that is through the food chain. Yes, because antibiotics are being used as growth promoters in the feeds which we are feeding our poultry and the livestock. And through the food chain, it is reaching the humans without the humans being aware of it. So that is one aspect of it which is actually a matter of concern, and it needs to be addressed, and I think it can be addressed through regulatory mechanisms, yes, of course, with a contribution from all of us as clinicians, as veterinarians, because this is an important contribution. And antimicrobial resistance as a whole is a matter of concern, because in 2019, WHO declared antimicrobial resistance as one of the 10 leading global threats to public health.
I think we will conclude at this time. Thank you.
Thank you,
for
sir.
a very comprehensive talk.
Let me tell you honestly, my area of interest is a little bit different, and it was my first sort of experience to get myself involved in antimicrobial stewardship. During this short span of time, whatever I could collect and whatever I could prepare myself, but still in future things would be better, and I think I'd be in a better position to deliver my talk and with confidence, and whatever queries would raise, I would try to answer those queries.
Thank you, Dr. That was a great effort.
Thank you, sir. Thank you, sir. Thank you, sir.
I will hand over this to organizers to for Philips.
Thank you, Chairperson. So this brings us to the conclusion of today's event. I now invite Dr. Haifa Ayman, who is the Associate Professor of Pathology at SKIMS, to propose a vote of thanks.
Assalamu alaikum and a very good afternoon. Well, we've had a galaxy of stalwarts here at this forum. So in that context, I can say that well begun is half done. And what better a beginning than this for NAM's Sciences-SKIMS, with so many distinguished personalities gracing the occasion. We hope that under the patronage of worthy director and convener NAM's J&K and Ladakh, Professor Dr. Ashraf Ganai, and the dynamic leadership of Professor Dr. Ejaz Ahmed Malik, coordinator NAM Sciences-SKIMS, NAM Sciences-SKIMS would go a long way in achieving excellence and scaling new heights. I, on behalf of NAM's committee SKIMS, feel privileged and honored to extend gratitude to honorable dignitaries, Professor Dr. S.K. Sareen, Director ILBS and President NAMS, Professor Dr. Umesh Kapil, Secretary NAMS, Professor Dr. Shakti Gupta, Director AIMS Jammu, and our honorable guest of honor, and all other dignitaries who spared time to join us virtually. A special thank you to the principals of medical and dental colleges who took time out from their busy schedules for the elaborate brainstorming and interactive principals conclave this morning. I'd like to thank worthy director, Professor Dr. Ashraf Ganai, Dean Professor Dr. Sharik Masoodi, and our respected chairpersons for gracing the occasion. Thank you to all the distinguished speakers for an interesting and enlightening session, and to the faculty members for their august presence. I'd like to acknowledge and compliment all the members of the organizing committee for their tireless efforts and dedication to make this event a success. Many thanks to the audience for your valuable time and patience. Sincere thanks to the departments of hospital administration, IT and photography, and estates, without whose support conducting this event would not have been possible. Thank you all.